Right, morning everyone. I'm sorry about those slight few moments of delay, but we are now live and able to start our meeting, not just for those in the room, but for the audience that's watching us as well. I welcome you to the Red Kite Room, which I had to ask, but it's the new name for the multifunction room. So we now come to the Red Kite Room. We are the Adults and Health Committee meeting in July 2022. Usual reminders that we allow filming and photography. You're welcome to tweet as long as it doesn't disturb the meeting in any way. And please, everyone, turn your phones off to silent or vibrate. We are being live streamed, I'm pleased to say, and a recording of the meeting will be available to view on the Council's website. If you wish to speak, please raise your hand. And in the afternoon, where we've got some members attending virtually, click the raise hand function on Zoom and turn on your camera. In accordance with our constitution, after around 2 hours, I will adjourn the meeting for a comfort break. There's no fire alarm test scheduled for today, so if the alarm sounds, I'll adjourn the meeting immediately and we'll all leave via the fire escape, which is situated halfway along the corridor outside of this room to the left, next to the kitchen. There are external stairs to the car park and assembly point. We did have a chat after the last meeting. You might remember that there are a couple of members who wanted to speak twice, felt their questions hadn't been answered, and we were up against time and worried about the later items as well and doing justice to them. But obviously it was a bit of an issue. So we had a discussion with the spokes, with Councillor Bowden as well. And what we're going to try to do now is to, at the spokes meeting, identify in advance where there are perhaps 1 or 2 items on the agenda that we want to give extra time to, and to try and agree that across both the administration and the opposition. So if everyone is aware of that, speak to your spoke from your political group if you feel that there is an item that you think needs extra time. Can't give extra time for everything, of course, but we hope that will be a better way of dealing with that problem. And thank you to Councillor Bowden in particular for that. We can always review it if there are additional items, but let's try that. Councillor Hay.
That, I must admit, is an improvement, but it doesn't get over the fact that when you ask a question, the answer that is given can quite often give rise to a supplementary question. And at the moment, we're not allowed to ask supplementary questions.
I hope that by discussing in advance where we want to give more time, that will help with that problem. You want to come back?
Yeah, I'm sorry, but it doesn't help because you don't know the answer that the officer is going to give beforehand.
I'll tell Councillor Bowden and then I'll try and sum up on this.
Thank you, Chair. First of all, I'm grateful you took up that suggestion, and that is much appreciated. And we'll definitely utilise that in the future for those relatively small number of agenda items where we can anticipate that there will need to be a rather deeper dive than otherwise would be the case. But in answer to the point which has just been made by Councillor Hay, may I just suggest that you additionally use your discretion throughout each meeting, taking all the factors into account, including timing, so that where you can see there is a legitimate question being asked, you can feel you might reasonably allow one individual to get another bite of the cherry, even if that means that others don't. We don't all have to be treated equally here, but I think we all need to be treated fairly. And sometimes individuals from both sides of this chamber, sometimes they do come up with really important and interesting points. And sometimes, with your discretion, it may be helpful for them to be able to expand on those.
Thank you. I promise you that's what I already do. I listen very carefully. Everyone is equal, but you're quite right to say that discretion should be used. I do attempt to use it. And as I'm sure everyone's aware, we have a careful planned time for the meeting. So what I'm doing is listening very hard to the questions and answers, but also seeking to keep to the plan. But I promise you I do exercise and will exercise that discretion. And I say that to Councillor Hay as well, because I think it's very fair what you raise. I'd like to welcome two people. I'd like to welcome Steve McAdam, who's Huntingdon District Council rep. He'll be joining us as new appointee this afternoon for the scrutiny section of the meeting. And so we really look forward to hearing from you on that. But you've asked to come and observe our proceedings this morning to get into the style and the method of this committee. You're very welcome. Thank you very much for coming, and we look forward to your contribution later. I'd also like to welcome Maria, who is a work experience person and waving at us in the office of the Chief Executive of the Council. And we are utterly committed as a council to apprentices, interns, and any other way that we can engage with young people and people across the population. So Maria, thank you very much for joining us. We hope that you will enjoy today's meeting. Let's do apologies. We've got an apology from Councillor Wilson, and Councillor Nessinger will be joining us and has joined us. So we get the leader of the council here. Everyone be on your best behaviour as her substitute. Councillor Ambrose Smith has informed me that he can't be here during the afternoon. And just a word now from Councillor Van der Ven.
Thank you, Chair. I believe Councillor Howell notified me also that he is unable to attend in the afternoon. I have to attend a funeral in the afternoon, so I'm very sorry on this occasion to miss the afternoon. Thank you.
Thank you, Susan, and our condolences for your family loss. We now move to anybody wanting to declare, any member wishing to declare a disclosable pecuniary interest or non-statutory disclosable interest. Councillor Howell.
Thank you, Chairman. Chairman, with regards to agenda item number 6, suicide prevention strategy, I was a member of the Samaritans for 10 years as a volunteer. I haven't been a member for about 20 years now, but I still occasionally do bits and pieces for them with regards to publicity, and I'm very openly biased towards them.
Good for you is my response to that, but thank you for declaring it openly. And Councillor Slatter, please.
Yes, along similar lines, and as any members who've read one another's declarations, I'm a member of the Campaign for Dignity in Dying, and therefore a supporter in the change in law for assisted dying on a clinic for the terminally ill. Obviously, the report is looking at generally other sorts of suicides, and that doesn't, I hope, but I think it's important that people are understanding where other people are coming from, as they say. I'm very much approve of Mark doing everything he can to deal with those sort of suicide. Just thought I ought to mention it. Thank you.
Thank you. I fully respect that members want to be as open and transparent as possible, and you've demonstrated that there, so that's noted. Now, any other declarations of interest? We now move, we've got no other announcements, just checking with Tamar. No. We now move to item 2, the minutes of our 17th of March 2022 meeting and the action log. The first thing is to approve the minutes of the meeting on the 17th of March. They're on pages 5 to 25 of the agenda pack. Does anybody want to raise any issues about the accuracy of the minutes? I see no objections, so we'll take them as carried. We now move to the action log, which is on pages 26 to 28 of the agenda pack, and was circulated to all members on the 12th of July. Are there any questions or comments on this? Councillor Hay, please.
Thank you, Chair. Yes, I do have some comments. Firstly, on top of page 25 at the start of Appendix 1, it clearly states at the top that captures the actions arising from the most recent Adults and Health Committee meeting, which I believe was the 17th of March. But on the top of the actual grid, it tells me the meeting was the 13th of January. Also, on page 26 and 27, there is, under the minute number 89, there is 4 actions. Can I ask in future that where there's more than one under the same action minute, that it's 89A, B, C, because when you query something, it would then be clear which ones you're querying. I am querying the first number 89 and the third number 89, which both state that officer chased for response and is ongoing, and the officer responsible was Catherine Goose. Now, it's 3 months or more since, or 4 months, since we had this meeting. Surely we should have had a response by now. And by just putting there officer chased for response, it could mean she chased for response last week, when, as I say, the meeting was 17th of March.
Okay, we'll take those 2 questions separately. On the first one, Tamar, about the most recent meeting and which date it was, can you just clarify that?
Apologies, that's an administrative error on my part. I have emailed the updated action log since the agenda was published, so members should have received that a few days ago, and that has all of the actions updated on it.
And did it have the correct dates? That's what Councillor Hay was. Was it referring to the January meeting or the March meeting?
Yeah, so that's it. The one in the pack has the incorrect date, yes.
Yeah, okay, so apologies, that was a mistake.
And I have sent round the action log with all of the actions updated, because we've received responses to those 3 actions as well.
A second point, though, which is if there are different actions on the same minute number,
that's noted.
Is noted. And then on the last point, we have received the responses.
We've received the responses, and that's been circulated.
Been circulated to
yes,
members,
to the whole of the committee.
Okay. Did you want to come back?
I obviously have missed that. Can you tell me when it was actually sent, and I can go back through my emails?
Yeah, I can. It was sent on the 12th of July.
And Councillor Bowden.
Thank you, Chair. I must admit I had missed that as well. It's excellent that there has been a response made, but that will not actually be in the public arena as a result of it just being circulated to members. Can that somehow also manage to get onto the public record as well, so that we do have the answer, which is clearly available to everyone? Thank you.
I can, yes, it's already been published on the website. I've published it on the website as well. I'm sure I have. Yes.
Not on the version which I downloaded this morning, I'm afraid.
Double check to that and come back to you at the break. So, anything else on the action log from any members? No, it's taken as agreed. Then we've got item 3, no petitions or public questions, which moves us to our first substantive issue, COVID update. Now, I think this is going to, subject to any changes, be the last time we'll have this as a standing item on the committee, but who knows what might happen in the future, so we can't say that for certain. And what we asked the Director of Public Health to do was to not just update us on the latest position, but to take a reflective look on some of the lessons learned, and to build on what we've learned are some very substantial exercises that have taken place to debrief both internally and with partners. It's a really interesting report, and I invite Jyoti to present to the meeting.
Thank you very much, Chair. Further to writing this report, the situation has in fact changed. COVID rates are rising again, unfortunately, and are around between 3 and 4%, about 1 in 30 people testing positive at the moment through the survey. Of course, testing is not available routinely for folks now. And that's largely driven by Omicron variants BA4 and BA5, which do not appear to be causing more severe infection at the moment, but are causing business continuity issues and continue to cause pressures on the health service, who are still required to follow infection prevention measures. The gist of the report is more about lessons learned, though, rather than the current epidemiology. And there have been a number of debriefing exercises carried out through the Local Health Resilience Partnership, the Cambridgeshire and Peterborough Local Resilience Forum, the Local Outbreak Management and Health Protection boards. I'll identify some of the common themes. There are some specifics that each of those bodies have identified, but there are also some common themes that emerge, so I'll focus on those. I think one of the things that has been identified as working really well is system partnership, system working, and the fact that we were able to draw on a wide breadth of skills and experience in shaping our response. The coordination of comms and the success of our communications across partners, I think, was regarded as a strength, and very good and strong engagement with our local communities was another area of strength. I think whilst there are obviously lessons to learn, from such a long and unprecedented set of events, I think it's really important to recognise that many people worked really hard on the response and with the best of intentions. And I think that does need to be recognised in everything that we now consider. I think in terms of areas for improvement, people felt that there could be greater clarity on roles and responsibilities. I think more consideration needs to be given as we move forward towards how we strengthen sustainability of our response and we support well-being of our staff. And then the other reflection was that more regular reviewing of our actions would be of benefit as we move forward. So we have responded to some of those requirements already. We have kept a small team. We're mindful that we need to be proportionate in our response moving forward, and we are starting to pick up business as usual, and there is a backlog of 2 years worth of activity for all partners to catch up on. So we do need to be proportionate in our response, and we have good protection from vaccination as we move forward. However, there could be a resurgence, there could be, as we're seeing now, in fact, there could be a new variant that escapes vaccine. And we could, in fact, have a flu pandemic as we head towards autumn and winter. So we do need to be proportionate in our response. We have kept a small health protection team to be able to flex and bend should COVID rates increase. We continue to work with the UK HSA on developing strong memorandum of understanding. We will build in more reviews and reflections as we move forward. And we are working to maintain and further build on the relationships with partners, for example, the university that we've developed through the pandemic, and schools, in fact. We are continuing to drive vaccine uptake, and we'll continue to do that as we head towards winter, and it's likely that there'll be a further COVID vaccine offer, and of course the flu offer. We need to continue to push on uptake for both of those. We have made a staff wellbeing offer. The CCG have made an offer to us, which can be tailored to different staff groups, which we are taking up. We are continuing to plan for the winter. Thank you.
Thank you very much. Councillor van der Ven.
Thank you, Chair. I just wanted to make a couple of points. I know colleagues will have other things, quite a few on the list there. I wanted to just make sure we really acknowledge the devastating impact on care homes of the hospital discharge policy. I think we really have to underscore that in any look back. Also, could we acknowledge, I think that at the outbreak of the pandemic, this local authority, like others, I believe we had a vacancy, it was difficult to fill vacancy in public health protection. And that's just, part of the overall concern around workforce and the whole question of developing workforce. And I think that should be noted. And then I really wanted to say how wonderfully effective our Director of Public Health, Liz Robin, was during the pandemic with her vlogs. I mean, she became someone that people talked about what did Dr. Liz say? And I think that was a real breakthrough moment for public health and this local authority in communicating common sense with the public. And she really nailed it. So I wanted to say thank you on a personal level, and also lots of good things to learn there. Thank you.
And of course, Liz left and Jyoti came and midway through the pandemic, and of course we pay equal credit and heartfelt thanks to you, Jyoti, as well. It's important, I'm sure my colleague Susan totally agrees that we put that on record as well. And I know you will say it's all your team and your staff and everyone else, but it's important to say. Can we go next to Councillor Bowden, please?
Thank you very much indeed, Chair. I've got a few points to raise, but I'll raise them all in one set of questions, and I won't need any supplementaries. First thing is, when you have a lessons learned exercise, the thing is you'll be looking very much at things which went wrong as much as the, things which went right. And there's always a danger of ending up being too negative. So let's start off by saying how remarkably well we actually did in a whole host of ways. Yes, there were mistakes. Yes, with the benefit of hindsight, there are things we'd have done in some cases dramatically differently. But overall, given from where we started and the fact that this came almost completely out of the blue, although having said that, Liz Robin was saying some 3 months before the lockdown began, there was a possibility of some problem on the horizon here. But given that it was almost out of the blue with no real preparation involved, it is astonishing how, not merely in this county, but right across the country, how things managed to be brought together and how people started cooperating who had hardly ever talked to each other before within the areas in order to ensure that we could manage to give the best possible help to our residents. And I think that when we are having something which is going to say a few things which are negative, I think that positive really does have to be stressed. Right, various points I'd like to raise. The first is on vaccine rollout. Yes, we will be having more vaccine rollouts taking place, including potentially joint, possibly, COVID and flu vaccines starting in the autumn. But between now and the autumn, I just wonder if some action can be taken by the director. Sorry to make it personal, but the Director of Public Health is our face, and particularly by the Director of Public Health, to try to continue the drive upwards on vaccine uptake for the first, second, and booster doses, because there are still people coming forward now for their first dose, and I know that might be surprising for many individuals, but it nevertheless is true. And among the I was going to use the word excuse, that's a bad word. Among the reasons given for people coming now when they're asked, well, why are you coming now? Oh, I haven't had time. I've only just got round to it. That's for the first dose. Now, I don't want to be critical of individuals coming for their first dose. It's excellent that they do. But we've recently had a really quite major study published in the States about the efficiency and effectiveness of vaccines in preventing death. And the basic number they came up with was that people who'd been properly vaccinated were 17 times less likely to die than those who hadn't been. Now, of course, there are variations to do with age and so on, but vaccination has been massively important in fighting COVID. COVID hasn't finished yet. People are still at risk. People are still dying with COVID, and in some cases from COVID. So my request to the Director of Public Health is, during the relatively quiet period before the next lot of vaccines come out, would she make a point of trying to get onto regional television to get the message across, you're still welcome to come for your vaccines. There are ways of managing to get your first or second or booster vaccine, and it's important to do so because it can save your life. The lessons learned was a very interesting report to read. And I thought that it came across extremely well, but there were some points which weren't raised. I have to say that I'm not sure that there was as much attention paid to comments which came from this committee as I might have liked to have seen. Councillor Gay, for example, on more than one occasion at these committee meetings, made some, with his more specialised knowledge that he has that the rest of us don't have the benefit of, made quite a number of very cogent, I thought, points and asked some questions, and I didn't really feel that they were taken on board as much as could have been the case. I made the point myself about fears towards the end of the main part of the pandemic that we were being perceived as being still too rigorous and too restrictive in the recommendations which were being made as to behaviour, and that isn't mentioned at all in the report that we've got in front of us. And what concerns me is that we need to continue to have massive public confidence in our public health operation, and it's really important that we continue to maintain the respect and the belief of local residents that what we are saying is the right advice to give at the right time. So I think that I would have liked to have seen some reflection, even if the reflection was that we got it right. I would have liked to have seen some reflection about whether we did get the advice that we were giving, we did get that right at the right time, particularly towards the latter periods that we were dealing with. One of the things that, I'm pleased you mentioned Liz Robin, one of the things that Liz Robin said to us on more than one occasion, and the Vice Chairman will be very well aware of this, I regularly challenged about the level of reserves that we have in general on public health. And Liz repeatedly told us, well, you never know, there may be something serious happening, there could even be a pandemic coming, you need to have those reserves just in case. And I accepted that at face value, but now I'm not so sure, and I just wonder, as part of reflection, whether we need to take into account the fact that we did have a pandemic, we had something far worse than we might ever have imagined, but we didn't need those reserves because money came from central government. So I just wonder whether that logic of the level of reserves we need to keep in case of something serious happening, whether that logic just needs to be re-examined in the light of our understanding now that if we are in that position, the money will be coming from central government. We won't have to raid our reserves to do what needs to be done here in Cambridgeshire. Finally, I'm not yet convinced, Chair, that we should remove COVID-19 as a standing item. Let's hope things get better. There's no guarantee that they will, of course, but let's hope they do get better. We're going to have to learn to live with COVID-19, just as we've lived for decades with flu. But as we lived with decades with flu, I'm sorry to say, we also, on occasion, died with flu. Some will remember Hong Kong flu and the hundreds of thousands of deaths which took place, in fact it was millions around the world, which took place with Hong Kong flu. And I fear, even in the best case scenario, that we're going to see something similar take place with COVID over the course of the years and decades ahead. So it's never going to go away. But I just would be concerned, it's entirely up to you what's on the agenda, Chair, but I just wonder if we keep COVID-19 on there for just a little bit longer until we're sure that there's nothing useful that we can say in committee. Thank you, Chair.
Thank you. And of course, we can always review agendas in our spokes meetings, and I'm very happy to do that. Councillor Daunton, please.
Yes, thank you, Chair, and thank you to Jyoti for the report. Just a very quick question on readiness for winter. You've talked about this, Jyoti, and it's also in the paper. One of the aspects of the dealing with COVID the first time round was the help of volunteers. And I wonder if we've kept, we can again draw on the expertise of volunteers manning vaccine centres and doing other work. That's one question. And linked to that, whether the issue of staff shortages across the board is going to make readiness for this coming winter more of a problem than it was the first time round.
Thank you for that. Councillor Slatter, please.
Yes, and it links in with something that Councillor Daunton has just said. I'm aware that there are obviously many people who've been working through the pandemic, nurses and related professions, who are probably reconsidering where they go next because it has been exhausting. You've already mentioned that there's a shortage of public health trained professionals, and presumably you would be well aware already of the potential there for that experience to be captured and to be developed and hopefully put at the service of local government and our related partners, and we are very lucky in having Anglian Ruskin in our area. I just wanted to be reassured that we're perhaps being a little bit proactive and talking about the courses and the recruitment that they're no doubt already involved in. Thank you.
Thank you. Councillor Hay, please.
Thank you, Chair. Following on from something Councillor Bowden said about people who have not had their first dose, I'm presuming that some people during lockdown felt it was safer to stay at home than come out and have their vaccination. I think we need to get the message across that there is still a grave danger to a person's health if they've not been vaccinated. We've seen that people who have been vaccinated can still catch COVID, but generally it's less severe. And I think that's the message we need to get across to people.
Thank you very much. And Councillor Murphy, please.
Thank you very much. So I very much welcome this report, and I believe it's too early to do a full lessons learned exercise, and I'm glad we haven't gone to into great depth. There is, however, it is welcome to have some reflections, because we are probably at the end of the beginning, but we are nowhere near the end of what this pandemic, this virus holds for us. And it's important to think about the points, the highlights, if you like, that can really help us when we go into whatever the next phase might be. And I think one of the key points for me that has really stood out in all my readings about the impact of the pandemic on the workforce, and I'm glad our Vice Chair highlighted the really intense pressures that there have been on people who've been dealing with, like your team, Jyoti, and and primary care and secondary care and tertiary care in health service. It's been, and people in companies and organizations all across the country, it's been really, really tough. And what I don't think we've really got to grips with is exactly how we get some recovery, some space and time for recovery, because if there is another pandemic wave that is has higher lethality than the current one, then we will be back to a sort of an emergency situation, but with very tired people. And so I think the well-being point is something we absolutely cannot gloss over. And I have yet to hear how we unpack that and how we really deal with it, because I'm just aware that in all sectors there's a kind of long-term fatigue, and and that's the people who are still outwardly seeming quite normal. So I think it's a really critical point that we have to think deeply about, and I think that would be a really good reflection to have, because I think we will, in thinking about the winter, I think we are going to turn around and demand more of people. Obviously we will, any winter we do, but this winter probably very much so. And will people have the emotional and physical reserves to deal with it? Would it be even reasonable to ask them to do those things?
Thank you. If no one else, a few words from myself. Oh yes, Councillor Gay first.
Yes, just to emphasise what the Director of Public Health was saying about the danger of flu. I would be much more concerned about that, and I'd remind the committee that the flu pandemic in 1918 killed at least 75 million people, and the average age of death was actually 27. So we need to encourage people to, particularly more the older people, to take up the flu vaccine. And I'd also observe that the current coronavirus is becoming endemic, and there are 4 other coronaviruses that are endemic at the moment and have become basically common colds and more of a nuisance. So it looks like that's the way that this is going at the moment. And in particular, there's one coronavirus that crossed over in 1890, which has been endemic ever since then and has not thrown up any more pathogenic variants since. So I think there is good reason to hope that this current coronavirus will become endemic and be more of a nuisance and less of an emergency in the future.
Thank you very much. And Councillor Ambrose Smith.
Thank you, Chair. I think Councillor Downton actually caught my little bit. There's no mention in the report about volunteers, the army of volunteers that were there, and how we actually keep them on board for the future. It's I know how tired I got as a volunteer, so that's important. But also how we actually can develop them next time, because there will be a next time. Thank you.
Thank you. Let me personally also make a short contribution. Obviously, when we became the administration, I personally took part in the local outbreak group with the Vice Chair and had many phone calls with Jyoti, but also meetings with health partners. I'd just like to place on record my personal thanks for that, and to be able to see firsthand the work that was going on, and it really was outstanding. I really like this report because I think it's a very honest and balanced report, and therefore can really inform decision making. So I also want to say thank you for that. Some of the positives I want to join others in underlining. The system partnership, the way that the county council work with our health partners, with districts and with others across boundaries in novel and innovative ways, often at short notice, but it worked really well in Cambridgeshire. Many of us, I think, had experience of that firsthand. And so that's something I think we should really praise, and praise our partners as well as all of our own internal efforts. Some of the communications was fantastic. We took a specific role in relation to that, and the videos in 20 languages that are mentioned in the report that we use nationally a lot, but came from Cambridgeshire. I think that was a fantastic effort, and I do take the point about continuing the communications on vaccines, and strongly agree with it. To all our social care staff, that we undertook our responsibilities throughout. You can ease, as the report says, the Care Act responsibilities, and we didn't, because we didn't have to, because we carried on delivering, and that's really an outstanding effort and contribution from all our staff and our partners who work on that. In terms of some of the problems that are identified in the report, I think the honest conclusion that some of the preparedness plans were met, but some weren't. So I think that's a sort of shot in the arm, no pun intended, for all of us in terms of going forward. The fact that staff redeployed quickly was great, but that we perhaps could have reflected better on what was the impact on what they weren't doing as well as what they were doing. I think that's a very fair comment. Like others, there was 40% higher than usual deaths in care homes, and it is proper to express our concern about that. I'm pleased the report does so. You know, it's my view that, and I'm sure several people's view, that it was government guidance that allowed people to be discharged from hospital while they were COVID positive. And that was a huge mistake near the start of the pandemic. So I think there's a limit to what we could do. And I take the points in the report about the difficulty of implementing ever-changing and often contradictory government advice. I think those are all important points to heed. But in the end, there's a national public inquiry that is beginning to look at that. And I guess that the real conclusions to that will come from that. And to put on record again, that Jyoti and our public health team will contribute to that public inquiry by contributing local data and information from us. I was also going to refer to the volunteers. I think so much that was done by people voluntarily in all of our communities, including some of ourselves. Absolutely, Councillor Ambrose Smith. And I think with Tamar's advice, I think, can we add on that we want to place on record our thanks to all of our staff, and then all of the volunteers, our partners and all of the volunteers. I don't think that needs to be a formal amendment unless I'm advised otherwise, but I think that would be a good conclusion to this report as well. I suppose I hope it won't have to be a standing item, but I think we have to keep it under review, and we certainly will do that. Jyoti.
Thank you. The review process was open to those participants in the boards to reflect what they thought was important in terms of what went well and lessons learned, and they were merely guided through some high-level prompt questions, so they wouldn't have been asked specifics about volunteers or comments from this committee. Richard's referred to the COVID inquiry, and I'm sure proportionality of response will be something that's considered by the inquiry, and probably wouldn't be appropriate for me myself to reflect on. I think that needs external scrutiny, really, and I'm sure it will be part of the inquiry work. With regard to reserves, we are planning to spend all of our reserves. That's the plan. We're not keeping any for a pandemic now. Sorry. Okay. And I think with regards to standing items, I think we should consider whether a pandemic response more broadly should be something that we reflect on as we move through winter. Workforce is definitely a consideration. We have a shortage of workforce in nearly every sphere: healthcare, social care, public health. With regards to public health, my team are exhausted and are now trying to recoup the backlog of 2 years of Thank you. We have shored up our health protection workforce for the winter. We've recruited more public health practitioners, health protection practitioners, and we have an interim public health consultant who can support us through the response. So I'm confident that we've got sufficient public health expertise to cope with the response over the autumn and winter. But that will come at a price, and I'm really keen that we try to maintain the impetus we've now got on recouping activity, and you'll see quite a few public health papers on this agenda that are about trying to address the broader public health issues that we haven't managed to do over the last 2 years. Charlotte may want to comment on social care staff and resilience as well. I just comment on vaccine before I hand over. Absolutely want to carry on the good work that we've done. It's been a partnership effort. It's not just public health, it's the CCG and the vaccine, the Think Communities team in the council that have worked together to drive forward vaccine uptake. And I think with some success, we have improved uptake in some of our minority communities that didn't access the vaccine. But we do need to keep the impetus going. We've got some behavioural insights learning to draw on, and I will take up your recommendation of getting on regional telly to promote the vaccine. Thank you.
We decide the editorial policy of the BBC here. You heard it first. Charlotte.
Thank you, Chair. A couple of the queries that I'd like to pick up, please. One was about the contacts, the opportunities in terms of the workforce. We do have really good relationships with the local universities, and actually have recently restarted conversations with Anglia Ruskin. So I'm confident we're doing everything we can to try and attract the right people in terms of workforce. In terms of social care staff, I think we are very aware, and I appreciate members raising these issues actually, because it really helps the staff to know that there's that level of awareness. We are aware that some of our staff do actually feel quite traumatized by what they've been through. Some people actually want to forget about it and move on, and some people have expressed a desire to have a more sort of bespoke support offer or facilitate a conversation. So we are actually in discussion with the CCG at the moment, who've got an excellent clinically led offer from psychologists, and we are going to be running a webinar for a very wide range of staff, including public health, which might then signpost individuals who need a bit more bespoke support. But certainly we are very aware that some people are struggling as a result of what they experienced, and we are acknowledging that very openly So thank you for raising it. And the other thing I would just want to say is that when we have a conversation about social care, we talk quite often about our own staff. We don't always talk about the staff who are really at the front line, and that is people working in care homes. And I think we'll probably find over subsequent years that there will be some real issues in terms of the care home workforce, who obviously dealt with some incredibly difficult situations. So we're also actively talking to our providers as well.
Thank you, and I welcome what you said about the webinar and what might follow, and perhaps that could go in the minutes, because I think that's a very important piece of news, and congratulate you for that. Our recommendations are A, to note and comment on the information in, no, I've got ahead of myself, I do apologise. Recommendations are, we're asked to note the update on the current coronavirus pandemic and the lessons learned to inform future response. And then we've added a recommendation to place on record our thanks to our own staff, to our partners, and to all the volunteers active across all the communities in Cambridgeshire for what they did during the pandemic. Are people happy with those recommendations? Anyone got any objections? Yes, Councillor Ambrose.
I may indulge you. I do have a follow-up question from what was actually been said by Jody and yourself, actually. I'd just like clarification, please.
Okay, I've had the scrutiny on this, so 30 seconds, but go for it.
Well, thank you very much for that. The first question is, you mentioned 40% extra deaths in care homes against pre-COVID years. I question that because I didn't know that figure. And the other question on Jody is, everything is needle vaccinations. Is there anything coming to the party regarding those who have got needle phobias who just cannot be injected? Can you help me on that? Any tablets or anything?
Again, a very concise answer, please.
There is a nasal application for flu vaccine for children.
Sorry,
for COVID.
you're talking about COVID?
No,
yes.
not that I'm aware of. No.
So those recommendations, any objections from anyone? Are people happy? Yes, they're carried unanimously. Thank you very, very much indeed. We move straight away to the 40%. I've certainly got the reference on my phone. I won't be able to get it during the meeting, but I'm quite happy to add it later.
It's just I thought it was 15%, but I'm willing to be told differently. Thank you.
Okay, I'm quite happy to share that with you after the meeting. Okay, we now move on, thank you for that, to the Customer Care Annual Report. That's item 5. It's on pages 37 to 76 of the agenda pack. We've put it up front again because this is a time for us to really listen to what our service users and what our constituents are saying to us about our own services. So it's a very important point in the year to listen to that. And Debbie McGrade, Acting Director of Adults and Safeguarding, will present this. Debbie, you're a long way away, but this is an important report.
Well, hopefully, although I am a long way away, everybody will be able to hear me. It is a really important report. It's the Customer Care Annual Report, and it provides information about complaints, compliments, MP and councillor inquiries. It provides us the learning from feedback and actions to improve services, but it's also just as important to share the good practice, where we get that really positive feedback. If we have recurrent issues, this leads to specific learning and development, as well as action plans for areas that require a more focused approach. So in summary, in 21-22, we received 226 formal complaints. This was an 8% increase. However, we had a 32% decrease in informal complaints. And part of that, we believe, is the lack of face-to-face contact during the pandemic that we've just talked about. And at times, delays in responses due to dealing with other competing priorities. We believe that may have contributed to the change in terms of the informal and formal, but we are focusing on that to try and understand what that actually means. It's also worth noting that in terms of the complaints, it is only 3.5% of people who receive a service that have had reason to complain. Complaints about care assessments and charging accounts, and charging account for the most common cause for complaints, followed by the provision of care. In terms of financial issues and the complaints we've received, for both recovery, invoicing and financial assessments. All 3 services have implemented service improvement plans over the last 12 months. So we're hoping that we see a decrease over the next reporting year. In terms of complaints about the care assessments, this is an area we are monitoring due to the various different aspects of those complaints, but we also know timescales have been a particular issue during the pandemic. And again, with our staff working virtually and gathering information virtually, that has created difficulties. In terms of a further breakdown, I've just summarised the outcomes of the complaints. So 12% were upheld, 32% were partially upheld, which means, part of the complaint we were at fault. And then it just goes on to say 22% were not upheld and 34% were closed or withdrawn. I mentioned the compliments earlier, so we've seen a significant increase in compliments of 77%. So we received 440 in total, which I think, given what staff have been working through, is an amazing achievement. And there are lots of examples throughout the report of those compliments, as there are also around about the complaints. We've given some examples at the end of the report, just so that you get a flavour of what those complaints are. There were 19 senior management reviews, and that's when the complainant isn't satisfied with the first complaint response, so we have a deeper dive. And we also had 5 local government ombudsman final decisions. The England average for those final decisions is 72% upheld, and currently Cambridgeshire sits at 64%. For all of the LGO complaints, we have a formal practice learning session, and that's led by our principal social workers, so that we can really understand the learning behind those complaints and how we actually got to, the complaint escalating to the LGO. I think within the report, you will note there are a couple of areas where there's quite, it's over the 3.5%. That's for our adult and autism team and our young adults team. But it is worth noting that these aren't individual complaints. It can be one person complaining several times. So, 6 or 7 times, but it relates to one person. So I think that's it in summary, and happy to take any questions.
We are running a little behind. Thank you very much for that, Debbie. So I'm going to suggest 2 minutes. You can take 5, that's what the rules say, but if you keep it to 2, it will help us catch up a bit. The first one is Councillor Daunton, please.
I'll be brief. So it's really a question about the complexity of adult social care and accessing what is needed at the right level and how one goes about that. And really, do you think that some of the complaints or some of the concerns stem from the fact that it is a complex system, and that maybe people find it difficult to find their way around the complex system and don't know how to access the particular part of it that they need? And if you do think that's the case, is there anything that we can do, if not to simplify it, then to have better pointers, both for people accessing the care, but also perhaps for us as councillors, so that we can help our residents more effectively?
Thank you. Councillor Van Ven.
Thank you. Thanks for the report, and thank you to those delivering the services in what is often a challenging environment, and it's good to see that reflected in the compliments. Just a note on formal complaints. I think often people, not everyone will be inclined to go through a complaints process. They're in a very stressful, distressing situation, and they really just want to have a positive outcome. And so I don't know how we capture the learning from what we might call informal complaints, but that's so valuable. And also for us as councillors to learn from that in this report. I was interested in section 6, where the mention of complicated communication. And of course, there are many different organizations and people working together. And I'm glad to see that there's a joint working protocol that we will be learning about later this year. That seems incredibly important to navigation. And so look forward to hearing more about that. Thank you.
Thank you. Councillor Bowden.
Thank you, Chair. And thank you, Debbie, for the presentation made. It was much appreciated, except for one word, which I wasn't happy about. And that was when you said, and this is to do with the care assessments and also with the charging accounts, when you said that you hope that it will be better next year. And I don't think that hope is the word that we would want to use in this context. Given that there have been changes which have been made, we're implementing changes in the administrative processes in particular, already have made such changes. I think the word that we should use is expect rather than hope. In fact, I think I'd like that minuted, if you don't mind, that we expect that next year when we have this report, we'll have a smaller number and a smaller percentage of complaints which are to do both with the timeliness and appropriateness of care assessments and also to do with the very difficult area of charging accounts. Now, I think, if you don't mind, Chair, I would like that recorded in the minutes so that we can refer back to it in a year's time. Now, I have a case in my division. It didn't ever even reach an informal complaint stage, but I was kept fully aware of what was going on, both through the assessment process and then through the charging process. I don't have the permission of the individual concerned to say anything about it, so I'm not going to go into detail other than to say that it was a traumatic experience for the individual concerned, absolutely traumatic. An individual who was more than capable of understanding things and being able to, far better than average, being able to deal with matters, but was left in a really difficult situation for a long period of time. Now, I think that it's easy for us to lose sight of the fact that we're talking about individuals here, individuals who very often are scared of the situation they're in, who are vulnerable, who are actually afraid to complain for fear of what will happen if they complain. So I think that it's really important that we don't just look at these in terms of numbers, but realize there are people behind them. And if there is a mechanism by which this individual would be able to speak to someone senior enough, not to go through their particular issue, but to explain what they experienced and how they felt about it, I think that might be helpful if it could be done to someone at a senior enough level. And if someone wished to contact me after the meeting to volunteer for that, I'd be more than happy to put this person, if they wished to, in touch, because I know this person wouldn't want others to go through what they went through themselves. Thank you.
Thank you very much. Next, we have Councillor Slatter.
Thank you, Chair. Firstly, 614 refers to the discharge to assess coordination between health and social care. Now, this is really, really crucial, isn't it? We all know this. We know why it's a good idea to discharge and then assess, though it sounds a bit back to front, because until somebody's home in their own setup, you don't really know the truth of the situation and how things are going to develop. So clearly, this is risky, but it is an absolutely necessary risk to take, because you can't usually take people's word for what they think they can do when they get back home, but they will usually be better back home. So I was interested to see this virtual room thing. I would like to know how it's getting on. I wish it very well, because that sort of, like you might in real life be able to go to a building and stick your head in there, say, did you know Mrs. So-and-so really can't wash herself, or whatever. I mean, I used to go and do these sort of assessments myself. You know, to be able to go and talk to the people who can help. And if that's working in a virtual way without people, without tying up the staff to be on a rota in a desk at a reception area, that sounds brilliant to me. That's one thing. Quickly skating over 615, you may well have corrected the typo for the light, tough assessments, though maybe you meant that. Down to 11, the councillor inquiries. I know none of us believe that it was just 11 or whatever. No, of course not. And Councillor Bowden has already demonstrated how important we can be. And also perhaps to take we are the ones who can complain without feeling it's going to be any callback on us. And so we are a really important mediator. I'm not saying that staff should have to record all the inquiries they get, particularly from people like me who's just new on the scene. But I don't really like to have this in a report, which shows a rather lackadaisical attitude by the councillors. I mean, we do make many more requests than that, maybe almost leave us out altogether, but we have the itemised ones for the MPs, and we know that there's a lot going on more than that. If it was just possible to just cover that, perhaps it's my pride that gets hurt in seeing it looks as if we don't care. So, thank you.
Thank you. I think it is in the report that there are many more informal inquiries that don't get dealt with by the customer relations team and formally recorded as complaints. I think that is already in there, but it's an important point for you to make. So thank you for doing so. Last speaker is Councillor Nethsinger.
Thank you. So thank you for the report, Debbie. Lots of good stuff in here, and lots of things for us to be considering. I just wanted to come back on the thing that Councillor Bowden wanted minuted, because I want to raise a slight flag around whether it's likely that we will have a reduction in complaints next year, given the pressure that there is on our services and our staffing issues and the changes that are being imposed from central government coming down the track in terms of the way in which assessments are done and the way in which the need to measure more about people's finances. So I just wanted to be really clear that while it is very important that we absolutely do everything we can to make sure that there aren't complaints, and I absolutely agree about the impact that it has on individuals and the stress that this assessment process creates for individuals, I don't think that stress is likely to get any less given the pressures that there are going to be on us in the coming year and the pressures that there are going to be on families in the coming year and the additional reporting that is potentially going to be expected from us in the future. One of the things that I think it would be helpful for us to focus on actually is trying to make sure that we are responding to complaints and dealing with complaints kind of informally and internally before they get to a formal process. And I think it would be really interesting for us to think about how we can try and put systems in place whereby people can raise concerns with us easily in an informal way that might then help reduce the number of formal complaints. But I just wanted to flag that I don't think I don't think any of this work is going to get any easier in the coming 12 months.
Thank you. And a few comments from me. I said it at this time last year when we dealt with this report, we should welcome complaints. We should think they're a good thing. We're dealing with some of the most serious issues in our society, and we're dealing with a lot of that. And of course, there will be errors. And I think the culture that we should have as a council is one that accepts there will be errors, doesn't try and cover them up, but it says we'll honestly try and understand them and use complaints as part of the continuous improvement of the services we provide. And that's the only reason I agree with a lot of your sentiments, Councillor Bowden, especially about people not wanting to go through the trauma of a formal complaint system. I agreed with many of your sentiments, but that's why I wouldn't be happy, partly for the reasons Councillor Nethsinger said, but also partly because I don't want to send a signal to our officers that we want you to reduce complaints. I'd rather send a signal we want you to increase complaints. Not because the service is getting poorer, but because we're being even more effective at flushing out where there are errors or vulnerabilities. And so for that reason, I don't accept that we should put it in the minutes, but I hope that we could put it in the minutes that you said it if you like, but we'll put in the minutes what I've replied, if that's okay, Tamar. Other points on the report, I do think it's welcome, and the individual quotes and case studies are great in the report, by the way, as ever. These are really important parts to humanise our understanding of these issues and the decisions that we take, and the fact that there are double the number of compliments than there are complaints. I think we should take some pride in that as well. I'm particularly pleased by the comment about our staff regularly having, quote, time to listen and to explain, unquote. That's such a simple thing, but it's absolutely fundamental to what we do. And so I was so pleased to see that and to see that said about so many of our staff. In terms of the concerns, I agree with what was said by Councillor Daunton and Councillor Van der Ven. the joined upness is the one that is most difficult to crack, and we can have all the protocols and the virtual rooms as we like, and they're very well intended, but in terms of the, if you want to call it customer experience, it's the thing that most frustrates people and people get most confused by. And that's not meant as a criticism. It's meant to say it's the challenge for all of us, and to turn the protocol words into action. And I do think our attempts to move towards care together, decentralisation, and more joined up working at the local level with consistent and continuous access to the same people rather than different people is absolutely fundamental to this, and that's what's really going to change that. Once again, I do applaud the honesty in the report where things are wrong. I think the fact that senior managers are not in half of cases dealing with reviews within the 3 months is worrying, but you say it honestly, and thank you for doing that, and I'm sure that will be noted for the future. And as the officers know, I dealt personally with a case about wrongful charging in relation to a deceased person, and I do think our charging systems weren't right, and again that is pointed out at length in the report in 6.1 and elsewhere, and we've changed them because of it. And that, again, that fills me with great optimism that we can take criticisms and then act upon them. So I very, very much welcome this report and support the recommendations. Debbie, would you like to come back?
Yeah, hopefully I've captured all of the comments and questions. So picking up on the complexity of social care, I would absolutely agree, but I would say it's wider than social care. It's the complexity of the system and the systems we work in. And often people don't know whether it's social care, whether it's health, whether it's primary care. So we do work very closely with all of our partners to ensure that, you know, we're getting the right information out there. We're not where we need to be, but we continue to progress that. In terms of the local authority, social care ourselves, you know, we're constantly updating our website, constantly getting information out there. But some of the questions I ask, so I often use my mum and my aunt, and I'm, you know, 81 and 82, and I will often say to them, you know, if you needed help, would you know where to go? And you know, often the answer is no. So we've got to keep on making sure that we get the information out there. Absolutely agree with that wholeheartedly. And then when the information is out there, even if it's the wrong front door, making sure that we deal with those inquiries and redirect people to the right front door. You know, I had an inquiry this week from a councillor about continence services. And I was able to share with that councillor where that the individual needed to go. So equally, I expect if that comes through our front door, that's what our practitioners will do. The informal complaints was mentioned twice, and that is one of the areas we are looking at, because we've seen our formal increase and our informal decrease. And it is an area that we really aren't focusing on, because we want people to deal with those inquiries at that lowest level and resolve as quickly as they can, so that we don't escalate to that formal place. So that is something we're doing a lot of work on, and the customer care team are doing some bespoke training with our practitioners and our team managers, etc. So hopefully that will improve. I'm just looking at my notes in terms of Councillor Bowden, more than happy, that traumatic case you described, more than happy to pick that up directly. In terms of the virtual room, so the virtual room is working quite well, and by the virtual room, we do know, we had a Health Watch report that in terms of D2A, we had a number of issues that we've worked through and teased out over the last 2 years, and that's not just the local authority, that's all partners working together. So as a result of that, where we feel that somebody is potentially not going to be discharged on the right pathway, at quite senior level, head of service, people will, through teams that they have open all day, will go into the virtual room and have that MDT discussion. There's always a manager for the virtual room that can make that final decision. So it is working reasonably well at the moment, and it's helping us to ensure that with the light touch, because we still have to do a light touch assessment in hospital, because you've got to have an idea of, you know, which pathway somebody's going to go on, but that gives us also the opportunity to dig deeper into what those issues may be for that individual. Have I missed anything?
Looks like no. Sorry, let me thank you then. I thought perhaps you'd have a final sentence, but thank you very much indeed for that. And thank you very much for the whole report for you and all who've contributed. The recommendations are that we note and comment on the information in the annual adult social care customer care report and that we agree to its publication on the council's website. Any disagreement with that from anyone? Anyone want to vote? No, is that agreed? Nods on both sides? Yes, so that is agreed unanimously. We now move straight on to the suicide prevention strategy. And we have Kathy Hartley and Joseph Davis, do we? We do, if they could come to the table at the back there. Kathy is consultant in public health and Joseph is suicide prevention manager. And they're going to take the seats and present the report, which is on pages 77 to 142 of your agenda pack.
Good morning, councillors. Thank you for having us to introduce the joint Cambridgeshire and Peterborough suicide prevention strategy for 2022 to 2025, with the recommendation to discuss and agree the strategy for final approval by the Health and Wellbeing Board. Using national and international guidance, this strategy has been produced as a collaborative effort with our wider mental health system to introduce our ambition that everyone in Cambridgeshire and Peterborough should have access to the right care and support to ensure that they do not die by suicide. The strategy is broken down in 6 recommendations to address this. Firstly, identifying risk and tailoring support. So that is using the data available to us to identify those most in need of support and ensure that our approach takes into consideration the different lived experiences and backgrounds of those we are working with. Secondly, we are seeking to enhance general and specialist support, so ensuring our primary and secondary care services are suicide aware and adopting a consistent approach. Thirdly, we are looking at improving crisis care and follow-ups, so ensuring people are adequately supported when experiencing a mental health crisis and they have access to the right care following de-escalation. Fourth, equipping the community, so raising awareness of suicide prevention and training the community to support those around them. Fifth, addressing self-harm, ensuring that those who self-harm are taken seriously and that we are encouraging healthy coping strategies. And then finally, providing support following a suicide. So in the tragic circumstances that someone does take their own life, we are ensuring that bereavement support is delivered to both the next of kin and the wider community. This strategy is for all ages and covers both Cambridgeshire and Peterborough. It will be implemented alongside a children and young people's mental health strategy and a public mental health strategy. And we will be measuring the effectiveness of the strategy through the following outcomes. Firstly, a significant reduction in inpatient suicides in inpatient care settings and no never events. Secondly, a significant reduction in the number of patients in contact with mental health services who die by suicide. And then finally, generally reducing the rates of suicide in Cambridgeshire and Peterborough in line with the national average. And that's it for my introduction. So thank you very much.
Kathy, are you also speaking or are you helping respond to questions?
No, Joe was giving the overview of the strategy and I'm here to help.
Thank you to you both. We've got a good number of speakers here. Councillor Slatter.
Thank you. We hear a lot about the influence of social media and the way in which that can intensify and escalate the problem for some isolated individuals. You don't mention that, I don't think, in the report, and I know it's a big ask to say, well, there should be somebody keeping an eye on social media, because it clearly cannot happen. But I think we need to have something in there that actually acknowledges the problem. You talk about equipping the community. Often that, I think, is about things like social media, enabling parents to know what the danger signs are, teachers to ask and listen the right way. Could we have some mention of that, please, even if it's in an aside on one of your already fine proposals, to actually, I think we need those words in there. it is notable that 46% of suicides are not known to mental health services. That surprised me. I thought we, on the whole, could see it coming and deeply regret that it happens. I suspect it's lack of mental health services, or even I fear people on the waiting list. And I don't know whether that 46% includes people who are on the waiting list, or whether being known to mental health services includes that number, which I fear is horribly high, particularly with young people. The other thing it doesn't seem to get mentioned is attempted suicide. And I think that probably is also a feature, particularly for young people. And I know that rather horrible phrase, cry for help, comes in, and that shouldn't in any way underestimate the pain and the seriousness of the pain. And it's just probably good luck that it isn't successful. Possibly older people do it more successfully. I don't know. But you didn't mention attempted suicide, and I'd have thought some sort of flag without labeling somebody should always be there. And it's recently, in my experience, that's not necessarily be flagged, even when a youngster is coming into the care service. So thank you for that. And thank you for bringing the report to us.
Thank you. Councillor Bowden.
Thank you, Chair. I have to say, in all my time on what was the Health Committee, and now the Adults and Health Committee, I don't think I've read a paper which has made me feel more sad than reading the paper that we had here. How tragic it all is. And I very much welcome the targets which are being set, in fact, the ideal being the 0 suicide target, and I very much welcome the efforts which are being made. I did give notice at the spokes, however, of one issue that I've got, and Councillor Slatter happened to mention it previously when talking about interests. And that is that the legal definition of suicide does, and I agree with Councillor Slatter, I think it's incorrect, but it does currently include those suicides which take place when a person who may be suffering dreadfully with a terminal condition chooses to end their own life. And that is still a suicide, technically, under the law as it currently stands. It's something which is not recorded particularly well by all accounts, and there are many cases where this happens and a coroner may find another reason for the death, sometimes supposedly in the interests of sparing further difficulty for the relatives, I've heard being used. So I think the statistics are a little bit uncertain about it. But what I would like to ask as an amendment to this paper, and I'm not going to ask for the detail of how to amend it now, but what I would ask for an amendment is that in everything to do with this strategy, that the suicides that we talk about should exclude those where we're talking about an individual at end of life with a terminal condition who chooses to have the time of their own death, who chooses to determine that themselves. I don't believe that it's appropriate for us to be trying to reduce those. I think it's appropriate for us to be supporting those. I think it's appropriate, as Councillor Slatter said, for the law to be changed on that. But I fear that among the statistics that we may have for the past and maybe for the future, and the Director of Public Health wasn't able to answer this at spokes because I think it's all very hidden, but I don't think it's helpful for those suicides to be included in the figures that are reported to us, nor in our targets for reduction. So my request is that we quite explicitly within this strategy exclude those individuals who are in that situation, so that we don't find ourselves reporting on numbers of suicides which include those circumstances, those tragic circumstances which I've just been talking about. Thank you, Chair.
That's obviously a very serious point, and I'm sure there are different views around the table about assisted dying, and that all views should be respected. There's a national policy debate about that. Whether and how we can deal with that in terms of our local public health work, I think officers need to answer, because there are things that we can and can't do, I think, within the existing framework. And so I think that's a matter, an objective matter, whatever people's views are. So I think that's been heard, and I hope that will be dealt with responded to in the summing up. Councillor Daunton is next, please.
Thank you. Yes, could you say a little about the target audience for the report when you were writing it? Who was it aimed at? How it's distributed and who you hope to read it?
Simple question, but an important one. Councillor Howell.
Thank you, Chairman. Chairman, I have a couple of little statements and then a question at the end, a couple of questions. With regards to page 92, I like the fact, and you also go on to explain that even further on page 106, about better information sharing, because sometimes people can get wrapped up in the rules of shall we or can we share this information about somebody when the person is in crisis, and sometimes it just needs an action. So I like that, and the fact that you've got a no blame culture with regards to that. I think that's excellent. Page 95. You say there, and you commented upon it in your statement, with regards to appropriate steps are taken following somebody who commits suicide, with regards to the community affected. And I think we should remember that very often, and I don't know if it's happened here, but when you think of somebody who has committed suicide and you have spoken to that person in a couple of days or weeks before, the first thing you think of is, what could I have done? I didn't notice any signs myself, and you start blaming yourself. So it's not only the family or close people to that individual, it's also the community in general. So that's excellent as well, very good. With regards to the document, there is a lot of action points in there, which are spread throughout. And I would like to say, who is going to carry out all these different action points? Because there is a lot, primarily training and training of different sections of the community, whether they be professionals or not. That's what my first question there. With regards to that training, is it going to be a one-off or is it going to be continuous? Because of course, new people come along and also new people there. And one of the things I just want to say, thank you very much, my questions about suicide, is whether or not we agree with the person committing suicide, it's their decision at that particular time. We might not agree, but at that particular time, that person is decided to take that action. And that's a very hard concept that sometimes we have to understand. It's the ultimate decision that they make. And it's a tough one. And I think that you've got to be very careful with how you actually look at the statistics, whether or not we've been successful. To maintain those statistics as we are today would also be a success. That's also be a success. To lower them would be ideal, but to maintain them as they are as well is also a success. Thank you, Chairman.
Thank you. Councillor Van der Ven, please.
Thank you very much. I should just declare an interest. I chair a community rail partnership, which is involved with Mind CPSL in a suicide prevention strategy around the railway. My comment is, I guess I'm interested in what this looks like at community level, and that mirrors a little bit Councillor Howell's question. But underpinning that, we have so many gaps in our workforce, both in the health and care system, but also in education and in settings where support at an early stage is so critical. It almost feels as though this strategy needs a strategy for the workforce that we're missing. And I'm concerned that the ambition is really going to be very challenging, because this workforce gap is unlikely to be resolved very soon. Thank you.
And last speaker, Councillor Hay, please.
Thank you, Chair. I have a couple of questions. On page 79 under 2.6, recommendation 2C, it goes on about promoting the use of safety plans between primary and secondary mental health. Promoting the use of safety plans in all healthcare settings and raise awareness for individuals how to develop their own, with the aim of keeping people safe until they can access mental health services. That last part about keeping people safe until they can access mental health service worries me, because it implies that there could be quite a wait before people are seen by the mental health services. We've already heard in an earlier agenda item under the action log that children and young people with mental health issues face an average wait for assessment of 26 weeks. And it just concerns me that people who might be on the suicidal borderline may well have to face a similar wait time. Also, under item 3C, it goes on about reducing access to means within the home and in a digital world. I don't really understand that, because how can we reduce means within the home of people committing suicide? We surely have very little control over that. So if they could just elaborate on why that's in there.
Thank you. A few comments from me. Firstly, I think much of what we do in this committee is talk openly about very difficult subjects, and therefore try and break taboos and stereotypes. And I think in relation to suicide, it's excellent that we're talking about this openly, although it's such a sensitive subject for anyone who's been affected by it. And I thank the officers for drawing up this strategy. As it says near the start of the report, they and we've chosen the idea of a zero suicide strategy, which is ambitious, will almost certainly fail, but should be our aspiration. I think many of our constituents would think that is the right thing to try for. And so I do support that in the report, although I do hear what Councillor Howell has said about that. So we'll all be listening to the responses at the end. Like Councillor Hay, I think it is incumbent upon us to recognise that if half of people who commit suicide are known to our mental health services, can we do better? I think we have to ask ourselves that question. Again, I will be very interested in the response that we hear. I'm glad that Councillor van der Ven raised the issue about trains, the second most common means by which people commit suicide. I know from past experience that for people who work on the railways, it's extremely traumatic. And so the trauma is not just for the person and their family and friends, but it is for those honest rail folk who do such a good job and don't deserve to have to deal with this as part of their job. So I'm really pleased about the extra work being done on the audit in relation to that. If I have a question, is probably, there was a previous suicide strategy. What's different about this from that, and why will this succeed where that didn't? It did. Suicides have gone up in Cambridgeshire and Peterborough. That's not criticising anyone, it's just a fact and it's in the report. But there were good things in the past strategy. What's different in this strategy that gives you some hope or expectation that it will be more effective in terms of its outcome? Finally, this is more of a process point, but I'd quite like to get it on record. It also relates to some of the items this afternoon. With the sort of relaunch of the Health and Wellbeing Board, we need to think carefully about not duplicating and not having the same reports going to both on every occasion, which is just going to add to a burden on our officers and confuse the public. So we're thinking very carefully when we plan agendas, and today we've decided to put 2 reports on that will go to the Health and Wellbeing Board, but just to alert you to the fact that we're trying to judge that quite carefully, to try and have clear and the least bureaucratic possible systems without denying anyone information or the opportunity to contribute where there should be a proper opportunity to do so. Officers to respond, please.
Thank you very much for all of your questions. So I've made a few notes. Hopefully I'll be able to answer them all for you. So the first point about social media, I completely agree. That needs to be in the strategy. So it is briefly mentioned under the reducing access to means within the home and in a digital world. A big part of that is engaging with the online harms bill, making sure that we are in line with the national guidance, and then specifically around sharing resources for healthy online behaviour. But more than happy to make an amendment to make that a bit more explicit if needed. Secondly, and this was raised by a few councillors, the issues to do with waiting lists, gaps in workforces. We are very aware of this, and this is very much a national issue. The way that we've approached it for the purposes of this strategy is focusing on, as was mentioned, keeping people safe until they're able to access services. I completely understand the concern around that wording, and again, that can change if necessary. But this is what we've been trying to do, is using a wider range of resources and community support to kind of bolster what support we have available whilst the waiting lists are remaining long, and then we can monitor the situation, but we can definitely feed that back to the wider suicide prevention strategy group. The point about attempted suicides, yes, 100% agree that also does need to be added into the strategy. We do have a lot of issues in recording attempted suicides at the moment, and it is something that is a priority for us. So we've recently had some funding to improve our real-time suicide surveillance. And within that, there is a specific requirement that we look into recording attempted suicides. So there are conversations ongoing about how we can not only better monitor the situation, but then also better support those who have attempted. So to reassure that the work is ongoing, but it can be more explicitly mentioned in the strategy itself. For the comment about those with terminal conditions, as you mentioned, this is a very complex issue and people do fall either side of the debate. So firstly, to mention that when we talk about euthanasia and physician-assisted suicide, this is against national guidance, national law, so we can't explicitly endorse that within the strategy. I do acknowledge the comments about for those who choose to end their own life due to long-term chronic pain, chronic illness, or a diagnosis of a terminal condition. That does require further discussion. I think it does need to go back to the group. But one thing that we are doing is ensuring that those who are suffering with physical health issues, that we are taking every step that we can to ensure that their mental health is supported and that their emotional pain is addressed, or at least that is the plan for the strategy moving forwards. In terms of the target audience for the suicide prevention strategy, so the document that you've been presented with today is very much for the mental health system, so professionals delivering services. However, we have discussed about producing an alternative version for the public in an easy read format to make it very clear that our overall goals for the strategy. The comment about there being a lot of action points and this being quite an ambitious strategy, we can completely take that on board. As mentioned, the zero suicide ambition is very ambitious, for want of a better word. But as mentioned, we had many discussions about, well, if not zero, what is the appropriate value? So that's why we've come with zero. And then in terms of delivery, it is very much a joint strategy. So working with partners in CPFT, the newly formed Integrated Care Board, police, education, voluntary sector, to make sure that that is adequately covered. We've also put together 6 steering groups for each of the priority areas that will lead on delivery of each of these, very much sharing the workload to ensure that we're all working on it together. Specifically around the training, so we've already been delivering that for several years. So we have our Stop Suicide community training delivered by CPSL Mind, as well as our GP training program. This is currently being funded by external NHS funding for the next 3 years at least, with the expectation that it will be carrying on afterwards. And yes, to thank you for your point about maintaining the statistics as they are can also be seen as a victory. That is something we're very conscious of, and why we've specifically included in that outcome about being relatively in line with the national average to reflect that. Oh, and then the point about reducing access to means within the home and how we have little control over this. So the reason we've brought that to attention is because from our real-time suicide surveillance data, the majority of deaths do occur within the home. We completely appreciate that it is very difficult to address this. So when we talk about reducing access to means, it's less about kind of going into people's homes and kind of hands-on managing. It's more about things like introducing safety planning so that people know what tools and support they might need in that moment of crisis so that they can keep themselves safe in the moment before accessing help. But absolutely, we can kind of elaborate on that further to be a bit clearer. And then the final comment around what is different in this strategy versus the previous strategy. So the previous strategy, the priority areas were taken directly from the National Suicide Prevention Strategy. And what we've done this time is we've carried those forward, but we've added in an additional layer, which is the lifespan suicide prevention model, which was developed in Australia, I believe. And this has much more of a community focus. So whereas the previous strategy had a very, very strong focus on the mental health system and professional services, this one, whilst maintaining that, has added in that additional layer of engaging with the community, just to give that further wraparound support. So we're expecting that that will make a difference. Thank you.
Thank you very much. The recommendations are to discuss as we have, sorry.
My apologies. I did say, Chair, that I would like an amendment to take place to this strategy, although I hoped that it wouldn't be necessary as a result of the comments which were made, and that is in that definition of suicide which this strategy will relate to. And I am concerned that the strategy, as we are being asked to pass it, will apply to those individuals I mentioned before in that dreadful situation, or the terminal condition situation, who might be suffering dreadfully. Now, I don't want to waste the committee's time, Chair, and I know that from Councillor Slatter's earlier comments that she has a similar philosophical viewpoint as far as this is concerned. If Councillor Slatter would be willing to agree with me that we should seek to have this definition of suicide restricted for this strategy, then I'd be more than pleased to move it forwards. If Councillor Slatter doesn't feel it's appropriate, I'm not going to push it, because if she doesn't, then clearly it wouldn't pass.
I've just looked at Democratic Services, and I think an amendment isn't admissible. So I don't want to, let me just check that with Tamar. Is that correct? Using you.
Amendments needed to be sent in before the meeting, but it's up to the chair. He has final discretion as to whether it's taken or not.
I am going to exercise my discretion on this occasion. It will be minuted what was said in the debate, and we've heard from the officers they will take it back to the suicide working group for further reflection. So that will be in the report, but I'm not minded to take an amendment against the rules at the last moment.
Should like to respond though, as Councillor Bowden has particularly mentioned me. I actually would not want to put officers in the position of what could be dubious legality. We know that public opinion is changing. I think as politicians, we should try and change the law. We can use their experience maybe to help our arguments, but I don't think at this stage it would be fair to ask our officers to find any sort of wording. I think we've raised the issue, and I really am so grateful to you for your support and putting into words things that I had been thinking, but I think it would not be fair. But thank you for the suggestion, and neither of us will forget the issue, I'm sure. With that, okay, Mr. Chairman? Thank you.
Thank you very much. I'm keen to move to recommendation, but as I say, that will be minuted, and we've already heard that the feedback will go back to the suicide working group. The recommendation is to discuss as we have and agree the joint Cambridgeshire and Peterborough suicide prevention strategy for final approval at the Health and Wellbeing Board. Does anyone want to vote on that? Any objections? Nod at me if you agree with it, please. Yes, I'm seeing that all around the table. That is agreed unanimously. Thank you. We've got about 10 minutes for the break. Let's try and make progress. Obviously, anyone can speak and raise questions on the on the commissioning items, but it may well be that we can move a bit faster on those. I do want to have enough time for the financial monitoring reports in detail. So section 7, sorry, item 7, section 75, extension for sexual and reproductive health services, page 143 to 150. Can we have a fairly concise introduction, please? Val Thomas, Deputy Director of Public Health, you're very welcome at the meeting.
Thank you, Chair. I will try and make them very brief because they're three very transactional different types of public health work. The first one, the section 75 extension for sexual and reproductive health services, is a request to extend the current section 75 for 2 years until March 2025. This reflects the impact of COVID very much in terms of people's behaviours and change in service deliveries. Consequently, we are undertaking a health needs assessment, which we will use to inform our services going forwards. And also, we would want to explore the commission options as well. Consequently, we feel to enable us to have time to do this, we do need an extended period. Secondly, our current provider, Cambridgeshire Community Services, is still very much in a recovery period post-COVID and also plays a key role in the ongoing vaccination programme. And probably this applies to other potential providers of this service. So consequently, the request is to extend the section 75 until March 25 to enable us to go through those processes.
Lovely, thank you for being concise. Any questions or comments from members? I don't see any, and I see some happy nods around the table. Sorry, I do see one. Councillor Slatter, sorry.
Again, a very quick contribution. Your mention of the non-face-to-face advice and provision, I think that is really helpful. And we're well aware, I'm sure, of people who don't have a safe place to talk, even on the phone at home. I would just like to suggest that if we can make any use of our own council assets in terms of the libraries and community centres or those sort of places where we can discreetly provide safe places, and if the health services can help us with this, I would really welcome that, because I think we just need to be taking things to people where they can take advantage of them. Thank you.
Thank you, Val.
Yes,
just to respond to that point.
Yes, certainly. I think particularly it becomes particularly important in terms of accessing young people, for example, and also in terms of prevention as well, to get those prevention messages out to those. Our service, which provides the prevention aspect of this, does work very much in the community, and uses different types of venues. So certainly we would see that a key part of any service delivery going forward.
Thank you. The recommendations are to commission a sexual and reproductive health needs assessment, to extend the current section 75 agreement with Cambridgeshire Community Services till March 2025, to authorise the Director of Public Health in consultation with myself and the Vice Chair to award a contract, and to authorise Pathfinder Legal Services to draft and complete the documentation. Any differences on this that we need to vote on? No, I'm not seeing that. Can you nod at me if you do agree? Yes, I'm saying it all around the table. That's agreed unanimously. Thank you so much. And we go straight on to, I'm just checking the time. Yep, we can perhaps do these two items and then have the break. We'll see. Item 8, modification to the integrated drug and alcohol treatment system. Val again, please.
Yes, this recommendation is for the investment that arises from the 1.8 million additional funding we've had from the centre as a consequence of Dame Carol Black's report into the shortcomings of the drug treatment services. The request of the paper is, or the recommendation is, that the current provider, Change Grow Live, continues to provide its service with these additional services added on. The rationale for that is provided in 2.6, and it very much reflects that there's a certain pressures to spend this additional funding as quickly as possible. The current provider has been very much in the development of the proposals, and the whole ethos of the additional funding is to increase cohesion. So the request, that is the rationale for the request to, through a contract variation, extend the current contract with Change Grow Live. Just one, 2 points to make about that. There is the money is very much tied to certain delivery requirements. It doesn't really allow for any flexibility and has very strict reporting requirements. And secondly, the challenge in that and the risk in that, and something that's been a theme throughout the morning, is the workforce pressures. And to be enable us to, the additional, the spend is detailed in the table in the paper, and that is very much workforce based. And I think probably that will be the hardest challenge of this. And this is something we feed up constantly through OHID from where the grant arises. Thank you.
Thank you. There are a few member questions and comments for this. Councillor Daunton first, please.
Yeah, thank you. There was a very good news report. I don't know if you saw it, with interviews with Dame Carol Black when the report was released, and also interviews with people who've been helped. And one of the outstanding things that came out of that piece was the importance of housing, the importance of a new start, and housing was really key to having a new start. Now, from what you've just said, I suspect that we're not getting enough funding for housing, or perhaps it's a difficulty of availability of housing. I don't know. Could you comment on that?
Thank you. Next, it's a few members on this occasion, but Councillor Bowden is next, please.
Thank you very much indeed, Chair. This committee in particular works best when we put aside petty party political differences and sniping and look at things from the point of view of the county as a whole and the residents that we've got. And so it's in that context that I'd like to say, and I think it needs to be put on record, how unhelpful it is, and this is not a one-off, but how unhelpful it is to have, well, always welcome an extra £1.8 million or something like this, but how unhelpful so late in the day to receive money with conditions that the money has to be spent within the current financial year. Almost more than a third of this money has to be spent within the current financial year, which is a desperately difficult thing for officers to organise. It's not the way to do things if we're going to get the best out of public funds. Now, this is not a one-off. It's been happening across a whole host of areas, way beyond health and adult services, but it just isn't good governance, in my opinion. So I'm saying that in the spirit of what should be good for the county and, for that matter, for the country.
And I'm very happy to welcome that comment and across party spirit. Councillor Howell, please.
Thank you, Chairman. I should add, as I should have at the beginning, I used to work in a street drug and needle exchange program for many years. With regards to this, excellent, I'm very pleased. Just one little point I want to make out with regards to 1.6 bullet point 2, it says there a treatment place for every offender with an addiction. This I've seen happen, something similar to this before, and what obviously happens then, offenders who cannot get a place on the programme will deliberately commit crimes so that they will be put into prison and therefore get treatment. So I think it's very good, but with that particular line there, we should or may experience a small increase in crimes to the extent that somebody is put in prison. Thank you, Chairman.
Thank you. Councillor Costello, please.
Thank you. I just have one question, really. With the concerns about getting staff.
Councillor Costello, just to help us, could you bend the microphone a bit towards your mouth? That's right. Lovely. Thank you.
And now I'm a bit too loud, aren't I? Shall I get back a bit? Yes, sorry. I just wondered, if you don't manage to get the staff and undertake all this work, will you have to refund some of this money?
Thank you. And a couple of brief comments from me. I do think that Dame Carol Black had the courage and insight to say some difficult things. And we as a council, we're responsible for these services. Were they said in Cambridgeshire County Council beforehand? Perhaps not. And we do have a duty to analyse the services we provide and be prepared to criticise when there are problems with the national framework. And I said that in the same spirit that I responded to Councillor Bowden. It's about us being brave enough to say things on our experience and not leave others to do it for us. I do want to, first of all, I do want to thank and congratulate our partners in CGL. They've been given some visibility in this report that perhaps they didn't have before, so I think that's also appropriate to put on record. And finally, as a consequence of the extra funding, the new frontline team in Cambridge will now be extended to a further period, March 2024, I believe. And that obviously is extremely welcome, given the problems that I know personally of so much homelessness is actually linked to drug and alcohol abuse. So I really welcome that. With all of those comments from me and all of the members, Val, would you like to respond, please?
Yes, thank you. I think the comment about housing and the comment around people going around the system really reflects the need when you're working in this field. Is you do have to work with partners across the system. You have to make sure that the services are joined up. We work very closely with our housing colleagues at the districts, because obviously housing sits with the districts. And during COVID, we did an awful lot of work to ensure that people coming out of the prison system, for example, it is a challenge, and we learned a lot during COVID about what good housing can do for people coming out of prison. But it's an ongoing process. It's that constant negotiation, and certainly for me, one of the main challenges that people, when they come out of prison, that they have somewhere to go, because then you get into that cycle of people coming out and they don't get the services, but to get the services, and it's to enable people that have the support and give them a chance to sort of come out into a community and thrive. So I think probably the whole network of partnership work around this really needs to almost be developed further to accommodate, because it's going to have more demands put upon it with this additional funding. But there is quite a very supportive partnership network around it, and the points that have been flagged up, I think anybody who works in the service is very much aware of the challenges and very alert to these challenges. It is I think they will continue, but let's say I do think people are committed to try and use our resources in the best way possible. Housing will ultimately, I think, not be solved overnight, but I do think there's a commitment to it locally, and I've been very impressed during the course of COVID of how the funding was used very proactively and helped a lot of people. In terms of the refund, it's something we get the funding that comes down through OHID, and my team have frequent conversations with them and ask, will come. Unfortunately, we usually know a few months before whether we can carry it over. We've had funding over the past couple of years, and they did agree for us to carry it over. But it does tend to vary the approach, so we never quite know until several months into the grant. Thank you.
Okay, let's move straight. Thank you for that. Let's move straight to the recommendations that we agree the investment proposals for drug and alcohol services. We commission the current provider, the drug and alcohol service Change Grow Live CGL, to provide additional services, and we approve a contract variation estimated at £1.8 million to the current contract, subject to confirmation of the final value of the grant. Anybody got objections and want to vote? If you agree, can you nod at me, please? And again, I'm seeing that all around the table, that's agreed unanimously. We're not quite at 2 hours, and I'm keen to see if we can finish the next item, item 9, Tier 3 Weight Management Service Procurement. That's pages 161 to 166 of the agenda pack. And you're doing a lot of the work this morning, Val. Microphone, please.
Yeah, sorry. This has arisen from the additional funding from reserves, which we are using to address the backlog in weight management services created by COVID. We do have a current Tier 3 weight management service that does offer some diverse services, but one thing we know about behaviour change services is that one size doesn't fit all. It needs a different type of approach. People are different, essentially. And we've gone through, we offer a one-to-one service, we offer a virtual service and a more intensive service. But there are other options out there, which we've learned in recent years. So the recommendation is, in contrast to the last one, is not to look for a contract variation on the current service provider, but to go out to competition to ensure that we have the broadest range of services on offer to local users.
Any comments or questions from members? Councillor Daunton, please.
Yeah, thank you. Maybe could you comment on working across collaborative working in relation to weight management? I mean, surely in some cases there are issues of poverty and unequal access to services, and we're looking at it through the lens of health here, but I hope health in the broadest sense and taking account of economic circumstances as well as health circumstances.
I think the issue with...
May I just see if any other members...
Sorry, I forgot.
No, they're not. One comment from me. I really think it's very good that we're seeing a proposal not to extend a contract. We've seen a lot of those, not just this morning in public health, but also social care commissioning. I think they've been the right decisions. We've supported them, so it's not criticising anyone. But what this does show is that our officers are scrutinising each one and evaluating whether it's the right thing or not. And that if it's not, they make a different recommendation, as you've done on this occasion. So I think we should just note that and thank you for it. Val, to reply to both points, please.
Yes. I think one thing about obesity is that, for instance, in Cambridgeshire, over 60% of people are considered to be overweight or obese. So we do try to offer the service as widely as possible. But where we know where we have greater pressures, then we do try to make it, the services that we commission are requested to make additional services in those areas or to be more proactive in recruiting people. And certainly we were part of the services, weight management service, also enlist the leisure services run by our district colleagues. So we have that full range of physical activity that's built into it as well. And a lot of those are in the areas where we see higher rates. But we are mindful of the fact that really it's very hard to say that now anymore that obesity sort of is concentrated in more challenged communities, but we do make efforts to make sure that to make it as accessible for people who find it challenging to access services, and particularly where you have for children as well, and to look at the referral routes from our partner organisations so that they identify people and give them the support and encouragement to access services.
Nod of thanks there from Councillor Daunton. The recommendations are to launch a competitive procurement for additional Tier 3 weight management service, to authorise the Director of Public Health in consultation with myself and the Vice Chair to award the contract up to £1.5 million, and authorise Pathfinder Legal Services to draft and complete the documentation. I don't remember having those recommendations about Pathfinder before, but they've crept in twice this morning. Perhaps we do need to say it. Again, are there any calls for a vote and disagreement? I'm looking around. No, can you nod at me if you agree this, please? And again, I'm looking all around the table and that's agreed unanimously. The Finance Monitoring Board is really important, and we try not to give insufficient time. We can do good justice to it and still have a full lunch hour. So can I ask you to take a break of 10 minutes maximum, which means that we're back at 20 past to start promptly, please. Thank you very much. That's 10 minutes. Oh, right. Sorry, can I just check? Oh, right. It's 12:02. That's even better. So it's still 10 minutes. Sorry, folks. But you get a better lunch hour. So it's in all of our interest. So 12, please, to be back promptly. Well done for getting back on time. And for those that got to the front of the queue in the coffee bar, I offer my particular congratulations. That was an excellent example of the productivity of this council and those who serve us. We move to the two items on finance. And of course, these are both important because it's not just about the financial consequences of what we do, but it has really important information within it about what's happening in terms of activities that leads to those financial consequences. And so I'm pleased that we can do justice to these reports today in terms of our timing. The first of the two reports is the Finance Monitoring Report for 22-23 as a whole. That is at pages 231. No, I've got that wrong. The first of these is the Finance Monitoring Report. Thank you, Councillor Bowden, as ever, for your support. We have Finance Monitoring Report March 2021-22, and that's on pages 167 to 230 of the agenda pack. And Justine Hartley, as ever, our Strategic Finance Manager, will introduce.
Thank you, Chair. So yes, we start with 21-22 closing report, and as you all know, we were reporting significant underspend across 21-22, and we ended with a significant underspend, as you can see from the report. So on adults and safeguarding, the final year end position was 9.2 million under, and that was a sort of mix of things. So learning disability, we were overspending on, but most of our other care types we were underspending on. And really, I think that goes back to the demography amounts that we built into the business plan in prior years. So we had been expecting growth in line with what we'd seen pre-pandemic. When we set the budget for last year, we didn't really have enough idea of what the impact of the pandemic was on those numbers and the shifts that we would see in sort of demand for care. So that's really what's driven those numbers, and that's part of why we've been taking money out for rebaselining, because we haven't seen the growth. It's really interesting for older people. The numbers that we had at the end of 21-22 were pretty much the same as they were at the beginning of 21-22. They went up a little bit in the middle, but they went down again. And we've also seen a shift from the sort of more expensive residential care end to higher need domiciliary care, but domiciliary care is obviously cheaper than residential care. So that, along with some grant funding, the grant funding impact is bigger in public health, but there is grant funding impact in adults and social care as well. So that's more or less what's driven to that sort of significant underspend on adults and safeguarding. Commissioning, we were 255,000 under, so a relatively small underspend. Public health, 4 million under, 3.96 that sits with this committee, and a small amount that sits with children's. Much of that is to do with the pandemic and to do with the fact that most of the public health staff were very focused on the pandemic, and the work that they were doing for the pandemic was funded by the Container Outbreak Management Fund grant. And so that created a sort of one-off underspend against the base budget. Additionally, within public health, obviously, we had difficulties recruiting to staff because there's so much demand for public health staff. And we've also seen impact on our services delivered by GP practices in particular, with their focus elsewhere. So overall, significant underspend. The public health underspend obviously got carried into public health reserves, and we will talk about the allocation of those in the next paper. The report also has in it the savings tracker for 21-22 and shows the savings that have been delivered, and it also has the final position on page 227 on adults reserves, which are now at 11.3 million, which is much higher than we've seen before. Part of that is to do with NHS funding for discharge, which we are using this year. Part of it's to do with the decisions that have been taken to create a risk reserve to mitigate the uncertainty that we're seeing, really, in terms of numbers. So it allows us to make decisions more confidently in terms of the budget rebaselining, etc., knowing that we've got that backup reserve sitting there that we can access if necessary. So that's all I wanted to say really on the 21-22 report, but happy to take any questions.
Thank you. I suggest that we have a substantive discussion on the public health reserve in the next item rather than this one. And obviously anyone can say anything they wish, but I suggest we do that so we have one substantive debate on that. Who would like to contribute questions and contributions? Councillor Bowden.
Thank you very much indeed, Chair. I'm going to make no negative comment whatsoever about the outturn on the adults side in terms of the budget variance. I think that it has been extraordinarily difficult over the last 2 years and in the forthcoming year to budget on the adult side. And I fear that this year's budget is going to be wrong, but by how much and in which direction, I wouldn't want to say. But I think that we are in really unusual times as far as adults is concerned. And it's really important that we work on the best numbers that we can and the best predictions that we can. But those we just have to accept we're at a time when those best predictions aren't going to be as reliable as they had been in the past. And that's unfortunate, but just a fact of the situation where we are. So I'd like to congratulate the finance side for doing as well as they have done in terms of managing to keep control of where we are and making sure that there is correct feedback into the system as a whole so that we do make the best use of the resources that we do have available to us. On the public health side, I do note that mention was just made of that 3.96 million underspend. We are told in paragraph 2.4.9 it's 4.001 million. I'm assuming the figure in paragraph 2.4.9 is incorrect, and just having confirmation of that would be useful. And as you say, we can talk quite separately about the utilization of that separately in the next item. But I think that it was quite clear that a significant proportion of that underspend was caused by a failure for there to be staff, not necessarily our staff, but the staff very often of the people with whom we contract, the failure to have the number of staff necessary to perform the services which we wanted to perform. And it's hardly surprising that there was also a large COVID effect last year of a redirection of attention. But this availability of staff to perform the services that we budget for, that hasn't finished. That didn't finish at the 31st of March 2022. I'm sorry to say that that is a continuing issue. How much of it is going to be a continuing issue this year is more difficult to tell, but having some indication about how much of that underperformance as far as budget is concerned, if I can put it in that way, how much of that is likely to be continuing into the current financial year because of lack of availability of our contractor staff generally. I think that would be a really helpful indication to have from any of the officers now, even though I'm not going to hold them to it. Certainly not going to hold them to it to the nearest 100,000, let alone to the nearest penny. But just having some indication of that would be quite helpful. Thank you, Chair.
Thank you. I want to raise a related issue to that in the next report, but I won't do that now, but just to alert you to that in advance. Councillor Daunton.
Yeah, I want to ask a question about recruitment and retention. Is this appropriate here?
So I think so, as Councillor Bowden has also raised a related issue. I think, why not?
So obviously recruitment and retention is very difficult across the board and across the country. Are there any opportunities for us to put more funding into training packages or retraining packages so that we are looking more broadly, not just recruiting from professionals in a particular sector, but retraining from outside a particular sector, and actually tailoring training packages, putting more funding into training packages so that we can draw on a wider pool?
Thanks. We'll get Charlotte also to comment on that when we do the summing up. Important point. We now have Councillor van der Ven.
Thanks. I have a similar comment to make. I wanted to say this earlier, but workforce recruitment and retention, which we have in this council been talking about for years around health and social care. It's not just since the pandemic. I mean, but this is a thematic issue. We talked earlier about having the COVID-19 update or some kind of report as a standing item on our agenda as, an exceptional concern. You could say the same about workforce development and, what we're doing locally, what we're doing nationally. It is absolutely relevant to everything. I'm very glad that this report is put in the context of people in communities. I think it's really good for us, even if we're skimming the other bits, just to have that awareness and context that, this is a system and there are relationships across. But I would just like to echo the workforce comments that Councillor Bowden and Councillor Daunton made and just sort of put it out there that I think we need to capture this in perhaps in a way we can talk about outside as we go along. Thanks.
Thank you. Councillor Nessinger.
Thank you. I'll be very brief. First of all, I'd like to thank Councillor Bowden for what he said about the budgeting, both over the past year and going forward. I think it is an incredibly difficult time for anybody to try and do accurate budgeting. That was the case partly due to the pandemic with different really unpredictable numbers coming in. I think looking forward, actually what's going to be really difficult is predicting the cost of care packages and the impact of inflation and other issues, workforce issues, on how much we're having to pay for the services that we're providing. And I think that in the coming year, it is very, very hard to know. I mean, I think we can probably all be aware that it's not necessarily going to be good news, but it is very difficult. And I do want to say thank you for recognising that. On the workforce and the skills piece, I also just wanted to add that actually there has been work going on. The CPCA, the Combined Authority, invested in facilities in Peterborough to try and help with training more staff and encouraging people to come into training. There is a good new facility up there. It's just that the pandemic also had a huge impact on the number of people who could access that and who were coming in to do training. So I think that the impact of the pandemic on the plans that had already been brought forward for trying to deal with those workforce issues also needs to be taken into account. And we now are in a very, very difficult situation in terms of workforce strategy across the whole board. I don't know how much, I mean, there is work going on, and I'm hoping that it's really well joined up across the CPCA and the skills strategy and all the things that are going on there with what's being done here and with the CCG. I think it is a really well recognised issue and has been for a while, but that doesn't mean it's easy to sort out. And I'll stop there. Thank you.
Thank you. Some comments from myself. I echo what has been said around the room about uncertainty. And I think it's just important to be honest about that with ourselves and then with our electorate. And that's what we're trying to be. So I welcome that element, including 2.4.4 in the report. We've not commented on the government stopping the hospital discharge money. So even though there's a temporary amount that will be spent that looks like it's comfortable, in reality, work that was being done is not going to be funded in future, and we're going to have to think very carefully about allowing that to simply fall on our set of responsibilities and what choices we make and the discussions we have with our health partners. I don't think that's going to be easy, and that's in 2.4.6. And I just put on record again, I've said it in meetings with our health partners, but they did commission CPFT to do work on hospital discharge that they might have commissioned us to do. And of course, it's their decision, and we respect that. And it doesn't mean that we don't have an excellent relationship with them, but it was unfortunate, it was unwelcome. And so it is something that the Vice Chair and myself, in discussion with the now ICS, have further discussed, because as part of making the ICS work, it's quite important that we have genuine partnership that works, and that did just raise a question mark about that. So I just say that in public to put it on the record. On the savings from charges not being met, you know, this is something we're in discussion with our officers about. The charging policy predates this administration, and in particular with the advancement of the anti-poverty policy that we've committed to and that emerging, it may well be that we want to, and the cost of living crisis that we don't need to rehearse all the arguments about at this committee, it may well be that we need to review some of those decisions, and just to alert the rest of the committee that we're in discussion with the officers about that. And then I share the concern across both sides of the table about recruitment and retention. I think it's useful to have the leader of the council here, as I think we have discussed. There appears to be a bottleneck in our work on this, and we might need some help that's not in the Adults and Health Committee's direct ability to affect. But I know from taking part in meetings and conferences with other local authorities that some of them are doing more than we are, to be frank, on the recruitment and retention issue. I am proud of the decisions we took earlier this year that put extra money both into our own staff but also into our providers. Those were notable decisions that I think make a real difference on the ground. So I don't want to suggest that we haven't addressed this very seriously, but I want us to do much more. I share the comments right around the table that we need to do more, because that's going to prevent us falling short going ahead, and it is a critical challenge for every authority, but we need to put more resources into it, in truth. And I personally have said we should launch a joint initiative with our health partners on this, because they're doing quite a lot on recruitment and retention issues, including on issues like car parking and affordable housing that the Vice Chair and myself were hearing about in the last week. And I think we could do more in truth. And £1 million of our underspend is vacant posts. £1 million. To me, that points to the fact that we've got to do something about it. So I will put on record as well that Charlotte herself is on a joint group with our health partners to look at this. So again, we are engaging. I want us to put more resources into this in truth. And just to alert Councillor Nessing, Kate Parker did present that Combined Authority report at this committee, so we're very aware of that and joined up with it. But it's a very proper point for you to make. Let me just check that I've covered all the points that I needed to make. Apologies if you just give me 2 seconds. Yes, that is everything on my list as well. Obviously, there was one substantive debate there, but also other questions and points. But I'll ask Justine, then I'll ask Charlotte to comment.
Thank you. So first of all, on Councillor Bowden's point in terms of the numbers, the 4,000,001 is the total underspend across public health. The 3.9 million is the underspend that sits within the remit of this committee. If you were to look at table 1.3.2, which is children's and young people, you'd see that there's an underspend on children's public health, which makes up the balance. In terms of...
Good try, Councillor Bowden, but it's a humorous remark. Don't look so serious. I was just making a humorous remark. Good try, but not quite right on this occasion. Please carry on, Justine.
I'm glad people read my report so carefully that they spot these things. In terms of workforce, I will let Jyoti and Charlotte talk about their own areas. What I would say is we are working across the Eastern region on a workforce fund. We got some money from NHS England last year, which is allowing us to do some pieces of work in terms of recruitment and retention on the social care side. I think I'll obviously let Jyoti talk, but I think public health actually now is in a much better position where a lot of the posts are filled. So post-pandemic, perhaps that's easing, although we have still got reserve funded posts that we are trying to fill. But there certainly is movement across the Eastern region, and a real recognition that the position we're in now is, we've got challenges, but with adult social care reform and the numbers of staff that we will need to be able to implement that, we've got even bigger challenges further down the line. So a real recognition that we have to act now to start to address those things if we're going to be able to deliver that.
Charlotte.
Yes, thank you, Chair. So in terms of the question around training packages and are we putting enough in? I mean, we have got a really comprehensive set of proposals at the moment. So we have an apprenticeship scheme. We're also very aware that we need to sort of continue to grow our own. And what that really means is taking people who don't have a social work qualification who are in our workforce and giving them opportunities to qualify as a social worker. We also have done some work to develop a really clear progression route for our staff who will stay with us if they can see where they could end up in terms of career-wise. And we also, I think, have a good internal training offer, and we are also developing, and Debbie has recently done a lot of work, I think, to develop our ability to bring in newly qualified social workers and make sure they've got the sort of practice guidance and professional guidance around them. So we're doing all those things. I do sit on the ICS People Board, and they have recently produced a draft workforce strategy, which I have said needs more in it in terms of the social care agenda in particular. So I think we're doing everything, but that doesn't mean that we couldn't do more. And I think Chair's right, we need to continue to learn from other authorities. And we also, so one of the decisions this committee did make not that long ago was to approve retention bonuses for our existing staff. And I think I mean, obviously I oversee children's social care as well now, and the situation in adults isn't where it is currently in children's, which is a lot worse. And Debbie may be able to tell us exactly what our current vacancy rate is, or roughly our vacancy rate. But Justine's right. I think unless we do something different now, then we are going to have difficulties. But unfortunately, I think this is a situation where we need to develop a kind of multifaceted strategy. We need to try lots of different things because we are very much competing with all our bordering councils. And also we have some people in our workforce who, as a result of the pandemic, I think, are sort of making decisions about what do they want to do in future. You know, we do a lot of work within adult social care to try and get a sense of how our staff feel about their jobs, how they feel about their line management, how they feel about the level of support they get. You know, is it a supportive culture? And we get some really good feedback from our staff, so that's all good, but I don't think we can take anything for granted, and it's probably going to be one of our biggest challenges, in addition to what Councillor Nessinger said earlier about increased pressure on care costs generally, and obviously the external social care workforce, which is also really challenging.
Yeah, just to say that I'm less worried about staff shortages in the public health team, and there is some post-pandemic movement and we are successfully recruiting to a lot of our vacant posts. I'm more concerned about vacancies in some of our provider services, particularly health visiting, who do have a shortage of workforce and increasing pressures and more demands in terms of being involved in safeguarding matters. And plus there's going to be inflationary pressures, I think, over the coming years that will impact on our ability to provide frontline services to the extent that we have. So I think there's a number of concerns moving forward in terms of our ability to provide a strong service, and particularly for the health visiting service. That's the one I'd be most concerned about.
Thanks, and I'm sure we would be the first to say that that applies to the providers in the social care area as well as the public health area. So I think we've had a very good debate around that. And for me, the question is, should we compete with our health partners in this, or should we have a single training and development approach that grows the market for both of us? And I am pushing to try and have that, but at the moment they're doing a lot of stuff, and I think we're just following, and I think we could put much more into that. Watch this space. Councillor voted again, sorry.
My apologies, Chair. I did ask quite specifically if, given the shortages of staff in our contractors that we had in the last year, how much of that is thought to be carrying forward into this year? And I just wonder if is it insignificant? Is it thought to be as significant as before, more significant? I fully accept you can't give a number, but are we talking about something which is potentially significant here?
And is this contractors in the public health space or generally? So I'm going to look at both Jyoti and Justine on who wants to answer that.
So we've generally reinvested the money. So with the health visiting service, we've agreed a package of training that the money will go back into to support that delivery of that service. So no particular carry forward from the health visiting service. You know about the underperformance in primary care, and that's part of our reserves spend plan now moving forward.
Thank you. The recommendation is that we review and comment, as we have done on the relevant sections of the Finance Monitoring Report as of March 2022. Anybody want to vote on this? Any objections? No? Can you nod at me if you agree? Yes, I'm seeing all around. I'm getting your neck muscles really well exercised today. So thank you very much. So we now move to item 11, which is the Finance Monitoring Report as of May 2022 and for 22-23. It's on pages 231 to 272 of the agenda pack. And Justine again, please.
Thank you. So this is your first report of 22-23. And at this stage, we are forecasting balanced budgets across both adult and public health. It's more nuanced than a whole series of zeros on the page. Obviously, so part of the reason that we are still forecasting to budget is because the baselining sort of catches this up. The rebaselining that went through Strategy and Resources Committee at the end of June. And so that's kind of taken into account, which means that we are largely where we expect to be for budget. But what I would say as part of that baselining, you see one number that came out, but there's lots that went on behind that. So we do know that we're shifting, as we talked before, in some of our types of care packages. So we've got more cost on domiciliary care, less cost on residential. So there are bits and pieces going up and down across the piece, and all of those bits are taken into account in that rebaselining exercise. So it looks quite bland, having zeros all the way down, and actually even doing June numbers, it's still looking the same sort of thing, but there are ups and downs in that between different sections of the budget. So I've drawn your attention here to those decisions that were taken by Strategy and Resources Committee, just for information. So there is the rebaselining of 3.5 million, and largely that is about the demand that we expected to see between the time the business plan was written and the 31st of March that we didn't see last year. So we know that those costs won't carry forward through into this year. And as I said before, we are doing a lot of work now to look at demand going forwards and removing those pre-COVID trends that we had previously been building our budgets on. And the second part of that rebaselining was about the uplift in the public health grant, and you can see how that's been allocated all to the Public Health Directorate for this financial year. The other key thing that was discussed at Strategy and Resources in terms of the interest of this committee was the public health reserves and the decision to delegate to this committee the application of the remaining unallocated reserves. So page 236 sets out what the current public health service commitments are, and page 237 has the proposals for the remaining uncommitted balance. Just picking up on Councillor Bowden's point quite significantly earlier, because I was listening in terms of use of reserves. If all of these proposals are agreed, there will only be 45,000 of reserves left. So we have shifted from that position of holding everything back. I would say not everything will be spent in this financial year, because several of these are multi-year settlements. I've tried to, if you look in the detail of the public health budget, I've pulled out for you how much of actual spend we expect to spend in this financial year, and I will keep doing that through the year for you. So at the moment in the report you've got, it says 2.2 million. If you approve all of these new things, it will be 3.9 million that expect to spend this year. So I think, yes, that's only half of it, but that's because we are committing to longer term proposals. Some of them go over a number of years. So I think that's all I wanted to say. Public health colleagues, I'm sure are here to answer any questions that you might have on those proposals.
Thank you. Who would like to speak on this? Yes, Councillor Bowden.
Thank you, Chair. Would you allow me 2 bites of the cherry? Because my second bite would be something quite different from the reserve issue, and one, it would be directed primarily towards you, whereas the reserve issue is obviously the thing we really need to talk about now, as well as the rest of what's in this paper.
If the second one is time limited,
thank you,
and we
stick
within the 5 minutes.
You might well give me a single word answer. Even worse, you might give me a 2-word answer. I very much welcome the additional information which has been provided. It's very gratefully received, and it really does help to make things more transparent. And I'm not worried about the odd £45,000 being left. That's insignificant when we're talking about the sort of numbers that we're talking about. My concern is this. In the last 6 years, as far as health is concerned, it has seemed to me that there is a systemic underspend in public health. And that systemic underspend is more to do with capacity, and particularly capacity so far as our contractors are concerned. Now, it's been this has been subsumed in the last 2 years because of COVID, which has massively distorted all of the figures. But I am yet to be convinced that that systemic underspend is changing and has been changed. Now, we're moving into a period, let's hope it's a short period, but we're moving into a period of much higher inflation. And that in itself has an effect in the other direction, potentially. And I certainly haven't made any attempts to assess what that effect will be during the course of a year, and particularly during the course of this year. But as far as public health is concerned, many of our contracts are fixed contracts and fixed over a period of time as well. So it may well be that there isn't as strong a short-term effect, inflationary effect, as might otherwise be expected. So my concern is that I welcome all the spend which is being suggested from the Public Health Reserve. I'm more than happy to support that, but it is being spread out deliberately and for good reason, I understand, up to 2025. And if we still have an underlying systemic underspend within the public health side for the reasons which I talked about, then all we are doing is continuing to build up these reserves year on year, and we will never get to a position where we have zero public health reserves. Now, I don't actually want to be in a position of zero public health reserves. What I'm saying is that we're failing to anticipate what the position is going to be, and having the underspend spread out over 3 years merely means that the actual level of public health reserve that we continue to hold is, at the end of each year, is greater than it needs to be. If there continues to be this systemic underspend that we've seen over the course, or certainly in the 4 years before COVID hit, which I think it would be agreed by the Director of Public Health, is probably still within the system. So that's my concern, and it's my challenge to officers.
Perfectly proper. I'm sure they will fully respond. Any other members? Councillor Murphy, please.
Yes, thank you, Chair. If I may, through you, ask what the officer, what you see as looking forward as the most potentially volatile areas in terms of expenditure, under or overspending. Do you have a kind of private list of things that you're potentially worried about?
Anyone else? No more comments then. So on the public health reserve issue, it is a perfectly proper question, and it's the officers to respond, so I won't respond to that. My own observation is that people and communities were 13 million underspent, according to these figures, and public health was 4 million underspent. It's a significant amount about it, but it's not out of line with underspending elsewhere in the authority due to the COVID situation. And although it's perfectly proper to ask the questions, I don't myself have concern about the way that this has been managed. In fact, I have every confidence in the way that this has been managed by our public health team. And we are fiscally prudent as an administration. And while there were uncertainties, it was right not to make commitments. So I think it is perfectly proper to scrutinise that and hold to account, so I don't criticise that at all. But that is my view on behalf of the administration. I'm also really proud and excited by the list of items that are in section 2.7 of the report, doing some really interesting things to prove health outcomes. We've not had those fully presented, but they're all in the report. The idea that we're doing stuff on social media and marketing to get to people who perhaps aren't using other messages, get to younger people really good, getting more money into our voluntary organisations in Cambridgeshire, doing some things that perhaps some others wouldn't in terms of prisoner rehabilitation and traveller health initiatives, the health literacy issue, which I think we've often talked about this committee in terms of particularly people from specific groups and poorer segments of our population. Really interesting stuff. And for the first time today, the new investment on what is called income maximisation. I used to call it welfare benefits advice or whatever we ought to call it, but it's actually adding to frontline help to give real money to people at the sharp end because they're struggling very, very badly. All of that I find really exciting, a relevant use of the Public Health Reserve, and something that across the council we should be deeply proud of. So I would like to thank our officers for, I know, a careful, deliberative process which has led to those recommendations being made. My second point is about the rebaselining, and I only say today what I said also at Strategy and Resources, but the truth is I'm uneasy with the £3 million baselining. I think it's the right thing for our officers to do because we're part of a corporate whole, so I don't disagree with the process or any of our officer conduct on that. But I think the uncertainties are so great, I'm worried about where the baselining should properly sit, and I could see Councillor Bowden agreeing, and I'm agreeing with him, by the end of the year. And I think I'm very worried that we set up a set of expectations within the authority that these are permanent baselining decisions, and then we find out we've got it wrong. And so I did say at Strategy and Resources, and I do put it on record today, that at this point in the year it's been the right thing to do, but we must be prepared as an authority wide, not just as a committee, to review that. And I say that with two reasons in mind in particular. One is the whole workforce issue. You know, we can do more to crack it, but it will cost us money to do so. And if we don't crack it, the people we serve are going to suffer. And so I think we have to put up a red mark that says we might need that and other money that appears to be underspent to have a major injection in relation to our spending on this issue. The second one is this, and I'm being very open by saying it, but the discussion that we're having between the Vice Chair, myself and our officers is looking at how permanent some of the COVID loss is. So we all tragically understand the COVID loss had that impact last year and the year before, but it will get to a point where if we're underspending in terms of so-called demand, I hate the word demand, but anyway, we're stuck with it. But if we carry on saying this is a permanent position in demand, how much is that because of COVID, and how much might it be because we're not properly identifying need and meeting it? And so the officers have, and I'm grateful to them, started some work on need and needs assessment just to make sure we're not missing out on so-called demand that we shouldn't miss out on, and that we are genuinely serving the people that we seek to serve. And if it shows that we are, all well and good, but a piece of work is underway about that. And after Justine has spoken, I'd be grateful if Will could say a few words about that as well, just to talk us the whole of the committee through it. Having said that, I think it's an excellent report as ever, and I'm extremely grateful for all the elements within it. Justine, would you like to reply?
So if I pick up first on the potential systemic underspend in public health, and actually also going back to your previous question, so we are paying sort of incentives to some of the GPs to try to get them to catch up on health checks and things. So all of that should drive more spend, but obviously, you know, we don't know what happened with the pandemic. We don't know if it will hit again and whether that will be diverted. So there is always a risk of an underspend, I think, in terms of that, or potentially an overspend if they really catch up. But as I say, at this stage, we're not forecasting. We've got nothing that suggests that we're going to underspend at this stage of the year. It is quite difficult with some of those areas because they're quite slow in billing us. So it takes a while sometimes. But at the moment, we've allocated out everything we can from public health reserves pretty much, and we'll see how it goes. What I would say is 4 million last year was very unusual, because of all that contained outbreak management funding. We do have some of that still left over, so there could be a potential impact of that in this financial year, but going forwards, obviously into the future, that will end. And so that wouldn't necessarily indicate a systemic underspend. Second question about most volatile areas of spend. And I think will pick up on this. But you all know inflation is such a volatile thing at the moment, and that goes right across our care packages. But in particular, we're seeing pressure on the learning disability packages at the high end of the market. Learning disability has always been one that can, I mean, overspends year on year on year. At the moment, we're forecasting it to come into budget this year, but there are real risks around that. The individual packages are much more expensive than they are for other sort of client groups, so it can change quite significantly. So I think that's my biggest risk, and I'm sure Will say the same. There is, a risk around demand picking up in a way that we didn't see last year. I'm not sure that we'll see that in the short term, but we might well in the long term. So the rebaselining, as I said, is really about catching up to the 31st of March position and a little bit of less demand this year. What I would say is if we do get it wrong, so we don't not spend because we don't have the budget. If somebody meets the criteria, they will be delivered the service. And so if we get it wrong, that could push an overspend, but I will remind you, we do have 4.7 million in the adult risk reserve to deal with that if that happens in this year. And in terms of business planning for next year, we do it iteratively, and as you've seen, we do rebaselining on a reasonably regular basis. So actually, if we need the money, then that would have to go back in through the process again. So it's not this is the end of it forever, because if we start to see the demand come back through again, we will change all of our assumptions and build on that. Yeah, I think that was all I wanted to say, but I'll perhaps hand over now to Will.
Will, please. Thank you, Justin.
Yeah, thank you, Chair. So just like to make a couple of points, really. The point about the unmet need, which is what I think you're referring to, Chair. We know that there's unmet need. We know that people during the pandemic didn't access health services for up to 2 years. We also know post-pandemic, we're seeing changes to the demands for our services. So we've got some demands for some services that are increasing and in other areas decreasing, as Justine's put in her report. We are keeping, though, a very watchful eye on those changes, and we're doing that in both the short term and the medium term. So in the short term, working with our providers to make sure that we've got the right capacity in the right place to meet those increased needs or increased demands for those services. Trying to support those providers where the demands have decreased, which is sort of equally important because that demand might come through at some point. And then in terms of longer term, working with finance and with our partners, particularly health, to understand sort of longer term, 2-3 year term trends. And at some point we'd like to bring the findings and of that back. The one thing that I would say, and in response to Councillor Murphy's question, probably our largest concern is around our provider market and sustainability. Certainly, things like the real living wage, for example, have been very impactful, but they are now working in an environment where we talk about workforce issues. They have very, very acute workforce issues and very significant costs just to retain workforce, let alone recruit workforce. And again, on top of that, they have inflationary costs. So we're working very hard with our providers to understand that, and as part of the business planning process, feeding that in. I do think we're going to have to take, quite significant decisions to shore up our provider market. And then the other thing I would say is we're very mindful of is that those workforce issues don't translate into quality issues. So where providers, for example, can't recruit or retain good quality staff, we're very mindful that if that were to happen, that potentially feeds through to a drop in the quality of service being provided. So we're working very closely with the market, and like I say, keeping very watchful overview and support.
Thank you very much for that, and thank you to Justine. The recommendations are, sorry, I'm looking up Councillor Bowden. You had your one question to
Thank you. And it is quite quick. And I gave you a more than a week's notice about this at Strategy and Resources. So it may well be that you'll actually be able to give the answer to this. If so, you will be in a minority, I believe, in this committee. I'm looking at, if you go to the appendix to this item, and paragraph 1.2.2, we have our public health forecast and the budget for the year and the actual that we've had so far this year, and the forecast outturn and the forecast outturn percentage. And you'll find that in the appendix under 1.2.2 for public health.
Could you just say the page number for speed?
I'm sorry, I don't have a page number on that. Oh, thank you.
Thank you so much. Could you say what the question is?
So as you see on there, we've got a budget for the year of £37.348 million.
I'm still not hearing a question. What's
this
the
is
question?
paragraph 1.2.2. Well, the actual amount for the end of May is minus 1.346 million. Now, I understand where that number has come from. I'm quite confident the number is correct. I understand there are three different elements which make it up. But I just wonder the value that we have in this committee and in all committees about giving this information, because first of all, I believe hardly any councillors understand what that actually means and whether it's good or bad or indifferent. And secondly, I think that hardly any councillors actually understand how that number is derived. I don't believe that it provides any value to members of this or any other committee at all, because they don't understand what it is. And if they did understand what it is, if there was some training to explain to them what these negative numbers mean, they'd then realize, oh, that's not really informative at all. It doesn't help us in our decision making. Now, you've had a week's notice of this because you heard me say it in Strategy and Resources. So you're now going to prove me wrong, and you're going to explain fully to the committee why there is that figure of minus 1.3 million for the actual, which is shown there, and my respects to you if you do so. But I'm saying this not in the expectation that it will change now. It's that I would like consideration to be given for this to be changed across the council when it comes to the next financial year. 7 years ago, instead of there being 4 columns there used to be 5. And in adults, I raised the point that one of those 5 columns had absolutely no meaning to councillors, and that was removed. I'm campaigning to get another column removed because I believe very, very few councillors in this committee and in this council understand what that column is, and it does not contribute to our understanding at all. Thank you, Chair.
Perfectly proper point. I will make a comment about the presentation of these reports, but on that specific figure, minus 1293, it's proper to ask Justine to explain that. I haven't called you again, Councillor Bowden. I don't recall calling you again. I've asked Justine to speak, please.
So I can understand where you're coming from. I would say that actually, I think that is a really useful column, because that is the real position that we are in now, as opposed to the forecast. And yes, it looks a bit odd with a minus, and you're quite right to come and raise it so that everybody does understand. I'm always happy to answer those questions. The reason it is a minus, and I sort of referred to this before, is because some of our health partners are very slow at billing us. And so we reserved, quite rightly, for Q4 spend last year, and we still haven't been invoiced for it yet. So when those invoices come in, they will offset all of that. And at this stage of the year, that's much more marked because those invoices will come in later. But as we go further through the year, you should see more of a tie-up between the budget and the actual. And I think if we don't have it, it doesn't give you that opportunity to ask those questions of us and say, why is that different? What is that telling us, you know, to help the understanding? So mine and other members of the finance team believe actually it is a helpful column to have in, but I respect that you might think otherwise.
Okay, my quick answer is this. Number one, when something jumps out that doesn't look quite right, it provokes a question. And I guess all of us as councillors, that's what we're doing when we're reading these reports. And the fact that it jumped out and you thought, what the hell does this mean? Probably is the report, well, I respectfully disagree, is probably the report doing its job.
Sorry, Chair, that wasn't what I said.
I'm actually in the middle of talking and I've not called you again, Councillor Bowden. Please exercise discipline. The second point is this. The big change, I think, is that we've got a whole people and communities directorate, and we've got page after page here, which is not reflected by what we as a committee deal with. Now, it's important that those things are done, but it makes the reading and the understanding, which is a really good point that I'm on, Councillor Bowden, I'm on your side on. We want to make this as accessible and understandable as possible, and therefore useful for our decision making. And I completely agree with you. That's a proper pursuit. But my own view is that although for internal reasons having a people and communities directorate is the right thing, I've got no problem about that. But I think the way that these reports are presented, and we have to look at the whole directorate rather than just what we're responsible for, is unhelpful, to be honest, and obscures some of the truths. I do accept, for example, on children's public health, that you have to understand the relationship between the two. So I understand that, and maybe that is more broadly there. But that's a change I would like to see. But that's not within the wherewithal of this committee. That would have to be an authority-wide change. But if ever it was done, I would think it would be a very good thing, and it's not the first time that I've said it. So I think that's answered the question. I think we can did we agree the recommendations, Tamar, or not yet? No, we haven't. So we now move to the recommendation, which is that we review and comment on the relevant sections of the People and Communities and Public Health Finance Monitoring Report as of May 2022 and approve the use of the 2.5 million public health reserves as set out in section 2.7, which we haven't talked about much, but we have talked about. Again, does anyone want to vote differently? No? Can you nod at me if you agree those recommendations? And again, I'm seeing that all around the room there, agreed unanimously. I had overlooked in my mind, and I apologise, item 12. How crucial is it that we get our item 12 agreed today? It's crucial. So we move to it. That's page 273 to 280 on the agenda pack, key performance indicators. And I think Tom Barden is joining us online, is he? I'm hoping, Tom, I can see your name up, so you need to put your camera on. Great. Tom, could you be very concise? If there are questions and comments, I'll give you much fuller time in reply. But if you could be fairly concise in your presentation, I'd be grateful.
No problem. Thank you, Chair. Members will recall that there's work across the council to look at performance reporting, and in the business intelligence team, we've been supporting officers in adults and safeguarding and public health and members of the committee to come up with the proposal, which is in the paper, which is being considered today. We've worked to try to make sure that we have a set of indicators here which are comparable, which are sensible measures of our key priorities across adults and health, and when taken as a whole, try to reduce the likelihood of perverse incentives. I'm very happy to take any questions on how the performance reporting works, and we have senior officers from the services here who will also have a view on how these indicators relate to their services. I'll stop there, Chair, in the interest of keeping it concise. I'm happy to take part in the discussion.
And just to say this, although that's been presented admirably concisely, this is the result of a huge amount of work that Debbie in particular has been involved with. We had an internal workshop that the Vice Chair and myself took part in, and there's been revision after revision on this to get to this point. And so I thank everyone who's been involved in that process. Member comments and questions. Councillor Slatter.
Yes, thank you very much for the workshops we've had and for sharpening what is often a blunt instrument as much as you can and making it subtle. The perverse incentives is always tricky, isn't it? It's more a matter of making sure I'm understanding it right.
end of page 275, beginning of following page, we're talking about long-term care and support. There's a key performance indicator, and then we've got any numbers here, which is the number of carers assessed. Could we clarify whether that is informal carers or not, just in case members of the public take a look at this? And if that is the case, perhaps you could nod. I'll carry on with my question. Yeah, it is informal carers. I thought so. It really makes sense otherwise. But I think it's important to point that out because, you know, a lot of people are interested in the carer setup and problems. And should it be related to the population of cared for people rather than the population as a whole?
Again, let's...
In other words, and do we actually know how many people there are who are cared for, that we are wanting to make sure we know how their carers are getting on? Thank you.
Thank you. Any other member comments or questions on this? Tom.
No problem. So I mentioned earlier that it's important to make sure these indicators are as comparable as possible. So the measure that's being discussed here that compares to the population is a standard definition which is used across the country. So that's why we're using the per 100,000 of the adult population in this indicator. In terms of the number of cared for people, then we of course have information about the number of people whose care is funded or arranged through the council, but we also, there's a large group of people who might make arrangements for receiving care themselves in a private separate arrangement. We don't have nearly as much information about them at the moment, and so we do make estimates based on market size of the total number of the cared for population, if you like. We do have much better information about those where care is arranged by the council. The information about the number of carers that there are, informal carers within the population, and the best source of information for that is through the census. So we saw in the 2011 census that there were somewhere around 60,000 people who said that they were informal carers across Cambridgeshire. And of course, we've just started getting the results for the 2021 census now. So I'd expect that information to come forward in time. The ONS haven't published it yet, but are running a publication schedule over the next couple of years to release the information. So that's where we will get information about that overall population of carers.
Thank you. No other questions. Just before I put the recommendation, two things again to make sure everyone's fully aware. These aren't the totality of the performance indicators used in adults and health. Our officers look at many more than these, but these are ones that we're saying we want reported at committee level, just to be very clear about that. And secondly, just to make sure again that you're aware, the government is bringing in national indicators that it's going to use and that will be assessed nationally by. So it was a quandary on whether we moved ahead and did key performance indicators ourselves or just waited for the national scheme, and also how far we departed from the national scheme. We wanted to a bit because we have local priorities, but we also didn't want to give our officers an impossible job. What our officers have done is, I think, come forward with a really considered view that takes into account what those nationally set indicators will be, but also melds in some local priorities and come to what I think is a very good compromise around that. But of course, if the national indicators are substantially different from what we expect, we'll have to come back and consider it further. Having said that, the recommendation is to consider the proposed list of KPIs and confirm the indicators which we wish to receive reports on. Anyone want to vote on this? No? Will you nod at me if you agree? I think we can agree, obviously questions and changes, but on the agenda plan, anyone got any comments or questions? We will deal with social care reforms in October. It is a bit late, but there's some good reasons for that. But we've never discussed that in substantive detail in this committee. We will in October. And does anyone want to indicate anything, questions or comments on the training plan? Okay, we'll take both as agreed. There's a number of really good training opportunities there. Please look at the list. Please look at the dates, because there's some really excellent stuff there. And I recently I did a customer journey with 3 other councillors on the committee. It's fantastic. You know, please take the opportunity to do it if you can. You really get a much better insight into the service if you do it. And I really encourage everyone right across the table to take part. We've got the appointments to outside bodies and internal advisory groups. Anything you want to add? Is everyone happy with the lists that you see? Any disagreement, any additional ones? The only thing I'd want to say is the liaison groups with the different health partners are completely open. There's no fixed number. And particularly to our Conservative friends, if you look down the list and you are interested in some, it would be really good if you did get involved in those. But that is to everyone on the committee, not to any one political group. It really does bring us closer to our health partners. So do consider that. Councillor Mayor.
Chair, I ask about the procedure. So if we are interested in one of those, do we just write to yourself?
Write to me and copy it to Tamar. It's actually Kate Parker that organises it, but to make it simple, write to me and then the rest will happen. Okay, have I done everything I should? Right, you get a lunch 3/4 of an hour rather than a lunch hour. Please, lots of questions this afternoon. Our health partners put a lot of effort into coming. It's part of our statutory duty. So please do put a lot of questions in during the course of the afternoon. I think we lose Councillor Nessinger as well, but we thank her for her day out at the Adults and Health Committee. We hope she's enjoyed it. The meeting is adjourned until 2 o'clock. We're just waiting for the YouTube channel. Apologies again for the slight delay of the resumed Adults and Health Committee meeting. Welcome back to everyone in the room and also those joining us online. This is the second half of our meeting. We are still live on the Council's YouTube channel. It's recorded and will also be published on the Council's website. People are welcome to use photography and recording and to tweet as long as it doesn't disrupt other members. There's no fire alarm planned, so please vacate the building for those in the building if you hear one, and please have your mobile phones on silent or vibrate. A number of people I'd like to welcome back to Steve McAdam from Huntingdonshire Council, who was also here observing in the morning, and then online I can see Councillor Jenny Gawthorpe-Wood. You're very welcome, Jenny, from Cambridge City Council. Is there anyone else online that I should introduce? Is Liz Every listening but perhaps not got your camera on?
Sorry, Councillor Clark, Samantha Clark.
Samantha, you're
yeah,
very...
I have technical difficulties this afternoon. So
don't worry, these things happen.
Yeah.
Sam's from Fenland, of course, and you're very welcome. Liz, I can now say, just to Sam, before I bring Liz in, I won't be able to see you raise a hand if you wish to speak. This is to Sam, not Liz, by the way.
Yeah, it's on and off, so I have to keep turning it off to get a connection. So hopefully...
If you wish to speak, I think there's no alternative to you just intervening and saying, Sam here, can I speak?
Okay, thank you.
And I'll hear it, even if we're in the middle of a flow, I will hear it, and then I won't miss you out.
Thank you.
Can I welcome Councillor Liz Every from East Cambs? Good afternoon, Liz, welcome. You're on mute. You're on mute, but you are welcome. And you're finishing a biscuit. I waited till you took the first bite of the biscuit before I asked the question, which is the old joke.
Quicker, so, yes,
Sadly, it's not true. And is Corinne with us online at all? She's online? Can I just see Corinne Garvey from South Cambs? Marvellous. Yeah, we saw you a bit earlier as well, didn't we? So welcome back. And Simone's with us. And so you're very welcome as well. Is there anyone joining us online who I've currently missed? Okay. So for everyone bar Sam, if you use the yellow hand, if you wish to speak at any time, I'll be watching carefully. And please do, your involvement is really important to us. So please don't hesitate to raise a hand and make comments and questions. So I want you to very much be part of this meeting. And thank you to everyone in the room as well for being here and for joining us. We also have representatives of the Councillor Taylor is here in a capacity as representing the Children and Young People Committee, and we also have Councillor Goodliff joining us. She's here for a short time this morning and is in the building, as they say, and they will be joining us for item 15, the Cambridge Children's Hospital in particular, but they're very welcome, both Councillor Taylor and Councillor Godliff. Please do feel free to participate in any of the proceedings this afternoon. Don't restrict yourself just to that item. I think that's all of the introductory points I need to make. So we move now to the agenda. First is item 14. And I did make a point this morning, but for the members that are joining us for the first time, we've deliberated carefully about what should come to this committee and what should come to the Health and Wellbeing Board, which is being revived and relaunched. And we're going to try and avoid duplication where we can, but there are some items that we think are also important to be informed to members of this committee and also our appointees from districts. But just bear in mind, we're deliberating carefully on that to try and make sure that we don't create too much burden on our officers or too much bureaucracy, but that also that we make sure people are well informed and able to be involved. So we're case by case, item by item, we deliberate on that and try and get it right. The first one of these is the consultation on the Health and Wellbeing Strategy. The strategy itself will be agreed at the Health and Wellbeing Board, but the consultation arrangements and update we felt should be reported here as well. The report is on page 313 to 336 of the document pack, and Jyoti Atri, Director of Public Health, will present the report.
Thank you, Chair. Much of the Health and Wellbeing Board and strategy development had been in abeyance because of the impact of COVID. And my predecessor had actually produced quite a comprehensive strategy before the pandemic, which had been widely consulted on, but was not launched. And when I arrived here, I felt that because of the impact of COVID and because of structural changes as a result of the Health and Social Care Act, there were opportunities that arose or issues that had arisen that needed to be reconsidered, and that in fact a new strategy might be warranted. And with that context, we've had a couple of development sessions system-wide, including our health service colleagues and councillors, members of the previous two Health and Wellbeing Boards for Peterborough and Cambridgeshire, to really consider A, the impact of COVID, B, the opportunities of collaborative working, and if we wanted to work together and how, and on what. And those two development sessions led to the agreement that the two Health and Wellbeing Boards did in fact want to work together with each other and with the developing ICB, so Integrated Care System, and likewise the Integrated Care System wanted to work with the Health and Wellbeing Board. And given that there were similar remits for both integrated care partnerships, forgive me for the many complicated acronyms here. Please ask if you're not sure. Shall I just describe it for people? So the integrated care system describes the whole system, all partners that will work together to integrate health and care. The integrated care partnerships are more partnership forums involving broader partners like the Health and Wellbeing Boards to work together on improving health and wellbeing. So we have agreed collectively that we will all work together and as far as possible to meet as committees in common. That has led to the Cambridgeshire and Peterborough Health and Wellbeing Boards now merging to form a single Health and Wellbeing Board that will meet alongside the Integrated Care Partnership. We also reflected on the joint strategic needs assessment, the data that was emerging post-COVID that really exposed or revealed existing inequalities and exacerbating inequalities as a result of pandemic control measures, and as well the impact of the unequal impact of COVID on different parts of our population, mainly our older population, some ethnic minority groups, and people living in our more deprived areas. We also reflected on the impact of pandemic measures on young people. And it's in that context that we've agreed what we will work together on and our priorities. We've agreed a mission statement, which is all together for healthier futures. We have 3 overarching health and wellbeing ambitions, which are to have better outcomes for our children, to reduce inequalities in deaths under 75, and to increase the number of years that people spend in good health. And we've also agreed 4 contributing priorities to deliver those overarching aims, and they are to create an environment to give people the opportunity to be as healthy as they can be, to ensure our children are ready to enter education and exit prepared for the next phase of their lives, and to promote early intervention and prevention measures to improve mental health and well-being, and to reduce poverty through better employment and housing. What we're now proposing is that we engage on the overarching strategy. There's a lot more work to do to develop the 4 priorities, and I'll talk a little bit about the timescales in a minute. We have now identified leads for each of those 4 priority areas that I've just mentioned, and we're developing a program management approach to support them to deliver a proper, developed and engaged strategy. The timeframes that we're working to are in partnership with the ICP, who have requirements to deliver a health and wellbeing strategy by December. So we're in a good place now. We're now going to engage our leads to what we're calling to deliver a stock take. So, where do they want to get to, and what's already in place to help deliver where they want to get to, and what are the gaps. And then there'll be further development over the next couple of months to get to the point in December where we have a fully developed strategy. And again, there'll be further engagement at that point. I'll stop there and I'm happy to take any questions.
Would you like to speak? Councillor Daunton.
Yes. I'd really like to have some comment, please, on access to GP services. I notice under 2.8, one of the sentences is our health service is under pressure in the way that people access healthcare, and preventative healthcare has changed. And I think that there is a real pressure on GP services and the way that GP practices are managed, and I'd just like to have some comment on where that issue or where that problem fits in the overall strategy.
Other comments and questions? Councillor Goodliffe.
Thank you, Chair. My question regards 2.13.1. It mentions prevention of conditions that cause disability and poor health over a long time. Can you also describe how the Health and Wellbeing Board will look at not only prevention of disability, but living well with disability, which I think is also a key factor in wellbeing and something that shouldn't be overlooked? Thank you.
Thank you. Other comments and questions, please? I'm also looking to all of our friends online. Yes, Councillor Gawthorpe-Wood. You're mute at the moment, Jenny. We're still not hearing you. I've got one of our colleagues here saying your mic might not be working, so you might just want to check your mic. I'll take the next speaker and then I'll come back to you, Jenny, if I may, but have a go at looking at your microphone operability. Councillor Slatter, please.
Yes, thank you. On the reducing poverty through better employment and better housing, welcome this, and especially in the context of health providers being big employers. I mean, I represent Trumpington, and we have this massive and wonderful biomedical campus with Addenbrooke's and Papworth on it, so we're very aware of that. Closely related to that, given that we would delude ourselves if we thought we could bring house prices down in Cambridge, inevitably we are talking about commuting. Waste of life though it might be, we have to provide for healthy commuting in the near term anyway. I would like to see some recognition of the power
as well as the duty of the health service employers to get together and try and deal with better provision of transport, essentially some form of public transport or other, and not necessarily in isolation, but sometimes working with schools and other employers. But it is good to have them thinking that it might, I would like to think that that would be part of helping people better in their lives, so that they're not spending endless hours, as well as a lot of money, and in discomfort or sometimes not safe when getting to and from work. Thank you.
Thank you. Jenny has gone off and probably she's re-logging in. Any of the other colleagues that are joining us online like to comment? Not that I can see anyone else in the room. So my own comments will take Jenny if she comes back in time. So firstly, thank you. I can't count the number of times we've discussed this strategy together in the last 6 months with our Vice Chair as well. But it shows the care and detail which has been put into the strategy. You know, clearly the big difference now is the buy-in of the health partners. I'm sure there was buy-in before, I'm not saying there wasn't, but now it's a stage forward in terms of it being an integrated system. You know, what I've observed and been part of in the last months to get us to this stage has been genuinely working together on these well, what's in the report. You know, to some extent it's saying things we all know, first putting them down and setting us off on a period of work to fulfill them, and it's part of a process. I do think, and again we've said this very often both privately but also in the committee and elsewhere, it is trying to shift towards prevention, towards measuring longer and healthier lives, towards tackling inequalities. I think that's a new emphasis that's been put down. Again, it was there before, but there's extra emphasis on it since Jyoti came as our Director of Public Health. And I think the element, the four priorities, we could debate this endlessly, but there's I'd like to comment, Jyoti, there's a sort of sliding scale between what many in the public would say is traditional health, and then looking at the social determinants of health, which are probably the big things that are going to change health. And I think the strategy that you bring forward has that much greater emphasis on the wider plane. May or may not be successful, but it's definitely worth trying, and it's definitely the right approach as far as I'm and the administration is concerned. But when you look at, for example, the second one, and with Councillor Taylor and Councillor Goodliff here, it's all about education of children and what education achieves. You know, that wouldn't normally be talked about in a strict, narrow health context in the way that it's been talked about here. And the fourth one about poverty reduction, better employment and housing, huge determinant of health, but wouldn't normally in the past have been dealt with in a strict, narrow health context. And I suppose the question is, how do you pitch that to make it workable? And we've discussed quite often, you know, you also have the combined authority that discusses these things. You also have the public leaders board that meets together with different public sector representatives across Cambridgeshire, including our chief executive. You know, where does health add value? What is the locus where health can do that others can't do, so that one, we're not competing with each other and duplicating, but also it really does make a difference in health outcomes. Really difficult question, actually. But I think it's a good one to discuss and to bring out into the broader the public debate. The second one is, you know, we are at a stage where we're launching a consultation about this. All of the discussion at the moment has been about with our friends and colleagues and partners. Now we're going to enter into debate with our citizens and residents about this. Can you tell us a bit more about that consultation, how it's envisaged to happen, how people can take part so that we can have that aired in the committee as well and go onto the public record. So they're my questions. Can I just see if Jenny is back? I'm looking at my screen. She is. Do you want to have a try again, please? Jenny Gawthorpe-Wood from Cambridge.
Hello.
Yes, you're being heard. Well done.
So I'm afraid I have missed a bit of some of the questions because I had to log out and in again. One of the things I wondered I don't want to get into the sort of detailed questions here as a demographer that I'd ask about the appendices, but I did wonder, standout diseases, you mentioned a few, and I wondered whether it was worth sort of setting those out. Things like children, when you talk about improving the life chances for children, you don't use the word life chances, but it seems as though that's what that's about. On housing, I think that, Richard, you've covered that. Is there a possibility that for detailed comments that we can email you later, Jodie?
Of course, yeah.
Okay, thank you, Jenny. That's all of the member questions and comments. Jyoti, please to respond.
Thank you. I'll start with the healthcare and preventative healthcare question. That to me fits under create an environment to give people the opportunity to be as healthy as they can be. And I think we've got to respond to the fact that the world has changed, and that's created threats and opportunities to how people access healthcare. We have, if you were here in the earlier part of this meeting this morning, we have used some of our public health reserves to support primary care in identifying risk factors for disease development at an early stage and putting in mitigating measures. We're also doing more health checks in the community, again, to recognise that the pressure that primary care services are under and to mitigate that, and to also go to where people are so they're more likely to take up our offer. How are we going to address the physical health of people with disability? I think it's important that we look at outcomes, equality or inequalities in health outcomes, and that's something that we will do with our health partners using the population management approach. More specifically, we are investing in work on reducing physical ill health of people with learning disabilities and mental health. I think we need to understand the physical disabilities issue in a bit more detail so that we can have more targeted interventions. I think there were some questions about travel to work. The combined authority are also partners in the development of this strategy and the delivery of this strategy. They have a big responsibility for transport. And again, I think the pandemic has brought about opportunities for people to access work remotely, which I think is an advantage that we might be able to make best advantage of. But affordable travel and linking up travel, active travel are areas that we will all be partners in developing a response to. What can health do? I could write an essay on that. I think there's been some concern expressed that because a lot of these priorities are embedded in the wider determinants, what's the role of the health sector? Well, the health sector are major employers, and I think they have a role in working with children in our more deprived schools to address the opportunities that there are of getting into work in the health service, to support them with work placements. There's lots that they can do around good employment, fair salaries for people, including in their commission services. There's a huge role they can play as anchor institutions in the local economy. And I think that's for us to work through as part, and they are committed to this. So we need to hold them to account through this process.
And that point about the value added and not competing with the other bodies and coordinating it. Could you try and address
I
that?
think that's the prize here, isn't it? That we do actively coordinate with our partners. And it might be that we agree that we're all going to work on some things together. So, for example, we might all agree that we're going to take a certain percentage of apprenticeships, so that we all do that in unison together. There might be other things that they're more uniquely placed to do, and that would be looking at the equal access to healthcare services and equal outcomes from healthcare services. I mean, that's theirs. We can help them with analysis and data, but that's their responsibility and uniquely their responsibility. I think there's more work to do in terms of the health and social care interface, and I don't know if Charlotte would want to comment on that in particular.
Yeah, definitely. Just to confirm everything that Jyoti's just said, I think there's huge opportunities in terms of the health and social care interface in this area. So yeah, definitely agree with that. Thank you.
Thanks. I think it was that last point from Jyoti, not particularly about social care, but about the Combined Authority and some of our other partners, that in reality, I think we're saying to them, you should have health in all policies the way we're trying to, and to explicitly look at the health dimension in the decisions you're taking more than you do at present. And we'll, as you just said, we'll help with analysis and support in relation to that. And I see that as being a very important part of this. You wanted to come back and say one more word?
I forgot to address your point about citizens and resident engagement. So we're working with comms. This will go on our websites, of course. I think there's a balance to be struck here, because we haven't got into the detail of each of the priorities. And that's where I would expect much more detailed engagement with relevant client groups. We're working with comms to develop a scope to market test this. I recognise some of the wording here is quite technical and professional in tone. We're working with comms to have some engagement in making that more recognisable to ordinary folks.
In everything that we do. Councillor McAdam hasn't taken part so far, so with your permission, Jyoti, can we do one more question if that's okay? Councillor McAdam.
Thank you, Chair. I just want to make 2 or 3 general comments, really. On the subject of travel, for years and years, I just keep hearing good ideas and intentions regarding improving travel, but I don't see it happening. And my worry is that while we discuss these things and we have all our good intentions, you know, that nothing's going to happen. Now, the government have got their levelling up, and I think we need a lot of levelling up in Cambridgeshire. And I'm thinking of places like Ramsey, for example, which has lots of development going on, but no change in the infrastructure and no apparent improvement in transport for people. I think we need to be quite robust, for want of a better word, in coming up with solutions for everybody, so that nobody is cut off. I mean, the towns and the villages, you look at somewhere like Woodwalton, as far as I'm aware, there's maybe 1 bus a day if you're lucky. So I think you can see the gist that I'm coming on to here. Okay, just moving on as well about children's health and education. I was very fortunate recently to have been invited to St. Peter's School in Huntingdon for a day of education for me, if you like, and other counsellors on how they go about their schooling of the pupils there. And what came across most impressively to me was not so much ticking boxes in performance and passing exams and other, you know, government targets, etc. What it was seen that the health and the well-being of the children was every bit as important, if not as important, of the education that was going on there. And I just got the impression that it was a lovely environment. We went round the classes and saw lots of well engaged, happy, children, etc. But I do think while teachers themselves are not social workers, but I do feel that the schools themselves are very important places for picking up on problems with young people, and that all young people should be able to feel that they can go to any of their teachers, with their problems, and that it will be dealt with seriously and properly. Thank you, Chair.
Those were big questions. I think points well made. Did you want to come back at all?
I'm not sure I've got much more to add. I mean, the travel issue, I think, is one for the combined authority, and for us to hold the combined authority to account on through the Health and Wellbeing Board. Great to hear that St Peter's has got an emphasis on health and wellbeing, and we do work with a number of schools on the health and wellbeing agenda, and actually have good sign up to our Healthy Schools programme across the borough. Thank you. County even. Sorry.
Don't make me laugh. Alex and Hannah, who've joined us, we're just about to come to your item, so thank you for your patience. Charlotte, just to add a word at the end of that item, though, please.
Yeah, if I could just add that we do also have a really excellent early help offer from Children's Services, so they are very linked into all the schools, and there's a very clear process. If a teacher or a head teacher has concerns about any children, I think some early help would be welcome. Then there is a really clear arrangement in place, which is well established, including at St Peter's.
Thank you very much. We now move to the recommendation, which is that we note and have commented on the proposals for engagement and consultation around the overarching Cambridgeshire and Peterborough health and wellbeing strategy. We normally don't have votes, we have consensus. If people though disagree, please tell me, and then we can make sure that we don't agree something we don't agree. I'm looking all around, everyone's happy. Yes, that is agreed. We now move, again, thanks to your for your patience, to the Cambridge Children's Hospital partners. We've got Alex White, I can see the project director, and Hannah Payton. I hope I've pronounced that correctly, and apologise if I haven't. We might have another of your colleagues, but I'm not seeing anyone else. I see the two of you. We have at the back a plethora of people, which I'm hoping one of them is Nancy Bostock, is that right? Yes. Another one is Rob Huishko. And you, sir, on the left, you'll have to introduce yourself, because I'm sorry I haven't got your name in front of me. But if you come to the table before you and use the microphones that are there. To the gentleman on the left, would you just kindly introduce yourself, please?
Yeah, hi there, I'm Adrian Lyne. I'm the Head of Strategic Engagement at Cambridgeshire and Peterborough Foundation Trust.
You're Adrian, all five of you are extremely welcome. To formally introduce the item is item 15, Cambridge Children's Hospital update. The report is on page 337 to 344 of the document pack. I just give advance notice that Councillor Goodliffe and Councillor Taylor, who are with us, you'll be asked to speak first in the debate, and it's very good to have our Children's and Young People's Committee representatives here and taking part this afternoon. I'm going to leave it to the formidable team that's before us to decide which order you're going to speak in, and also just to hand over to each other rather than come back to me, so that we can hear and see your full presentation.
Thank you. Thank you very much, Chair, and everyone for inviting us back. It's about 18 months, I think, since we came to present on our project, and it's great to be able to come back and illustrate some of the progress that we've made to you. So I will try and orchestrate the various elements of the project. It's complicated, and I'm not sure how much prior knowledge many of you have of the project. So we intend, next slide, please. We intend to outline and just rehearse the vision and aims of the overall project, and why is this needed. Alex, who's joining us online, will give you a sort of live update, if you like, on where we are with the project. And Adrian, who's led the engagement piece, which was of particular importance in the last 18 months, will finish off. I will start off with, next slide, please, with Nancy to outline the whole new way that we propose with this project. But I'm hoping that we will give you a sort of summary in a couple of minute video about what the essence of this project brings to Cambridgeshire and the region. So hopefully, electronic gremlins allowing, this should be a 2-minute video with some sound. If not, we will move swiftly on to
This is where we will cross our fingers. Give it a chance. There's somebody somewhere pressing buttons.
Someone's, yeah, pedaling somewhere.
Let's give it a chance to work.
It's actually from YouTube now. So if there is some sort of challenge with that, there's the link. Feel free to watch it. It's really a great capture of.
We're just deliberating whether we can go on that link ourselves from this end.
There's probably some firewall issues.
A nod or a shake. We're just going to check that. We might as well. It's a 2-minute video, and I've been told in advance it'll just help.
It gives you a good snapshot
So
of
just give us a second just to check
our vision.
You go back to the start and then put the volume up. Would you like to speak over the video? We'll show the video and you perhaps speak over it.
Yes, well, I mean, what it's trying to capture, and I will come back to some of this around the vision, is the underpinning USP, if you like, for our project is integrating mental and physical health. And these are examples of children who have both physical and, not at all surprisingly, mental health aspects to their ill health. And we will tell you a little more in the presentation, but these are examples of children where coming together around their healthcare and the support of their families works so much better than the current separated approach to physical and mental health, and we are looking to integrate this in a building that is designed to do this in a way that actually hasn't been done anywhere else in the world, so that we will have children cared for by mental and physical health professionals in the same spaces. So a hospital that's specifically designed to safekeep both physical health and mental health patients. But within Cambridge, there's also a real focus on moving research to early intervention, early diagnosis, early treatment to change health course over your life, rather than continuing to do what we do now, which is treating a great deal of illness and disease in adult lives. So that's a very poor reflection of Stephen Fry's speech over the top of that. So I do encourage you to see it in its full glory.
I was thinking that you had a remarkable resemblance to Stephen Fry, but I wasn't going to say anything.
Well, it's definitely Stephen Fry on the video.
Embarrassed you. Thank you to Rhiannon, who allowed us to at least see that video with the captioning, and well done there for praising it for the audience.
So,
thank you very much. Please continue.
So thank you. So just to remind you, why are we going through this, and why have we been after this for at least 20 years? And there are three major challenges that make the case for change. The most important, and I think it's a key reminder for everyone involved in this project, that this is a regional offer. This is to improve the quality of care and specialist care for children across the region. And of course, already, both in mental health and physical health, we are caring for children in Cambridge, 70 or 80% of whom come from around the region. They're not Cambridgeshire and Peterborough children, but they travel to us. And so as the last region without a children's hospital, we've rather been left behind with children and families needing to travel out of region for some of their specialist care, not only because of capacity, but also our ability to get them into an appropriate space. As far as the local challenge is concerned, we are still in facilities that are, 1970s designed, open wards, where specialist care for children who now have to stay with families much longer than the type of conditions that they saw in the 70s needs to be resolved. We know that the mental health inpatient facilities at Fulbourn are listed to close in 2028, and they need to be re-provided elsewhere. So instead of going down the road of repeating what has happened already with a separate institution or a separate building, we're proposing this integrated model on the Addenbrooke's campus, benefiting from both staff and patients integrating. And we also want to provide better for adolescents. So there's currently no pediatric provision for 16 to 18-year-old, and they fall very much between pediatric services because we don't have the capacity, and adult services who arguably don't have the expertise or the capacity to look after them. And with the University of Cambridge, I think we are wanting to address what are rather dismal national benchmarking figures on our pediatric healthcare outcomes. And I think bringing the University of Cambridge to the tune of 5,000 square meters into the building, next to the clinicians, into where the parents and children are, and focusing that on early diagnosis, early intervention, the strength of the genome and genetic power of the campus, I think really runs a very high chance of us delivering healthcare in a different way. So it's mental health, research, and regional solutions that we are trying to address here. Next slide. I think this is captured in what I've just said and what the intro said. Physical and mental health in the same building, purpose-built. The child and family, of course, at the center. And this is a small building. We've modeled the scope of the building for 2034-35, but in essence, there are only 4 or 5 additional inpatient beds. So what we are proposing with this is to leverage the expertise around the region, to local providers, to support children and families in their homes and closer to home, to provide support to the community services, primary care, and there is a significant chunk of space allocated for school. School both for the important longer stay mental health patients, but also for the provision of physical health patients who now are staying longer and currently have a dismal provision. So it's a regional offer. There's 1.5 million children in the region, and it's high time we did better for them. Research I've mentioned, and we think that if we put this together, we genuinely will come up with a new model of care and a new way of thinking about children. So I'm going to hand over, I think, next slide, please, to Nancy, who is my mental health lead colleague, to tell you a bit about the whys and wherefores of integrating mind and body.
Thanks, Rob. Hi, everyone. My name is Nancy Bostock. I'm a consultant paediatrician, but I work in mental health care with children. So I think to understand the vision of this project, we really need to think back a little bit to how healthcare is provided at the moment. So I think everybody's had experience of healthcare, but historically we've really separated mind and body. So if you have what's thought to be a primary mental health problem, you're treated in a different trust, in different buildings with different clinicians from if you are considered to have a primary physical health problem. And Rob's talked about that. So at the moment, we treat children with mental health difficulties as inpatients in Fulbourn and with physical health problems in Addenbrooke's. This is really problematic for families because as I think we're becoming increasingly aware, you just can't separate mind and body. There are no physical health
problems that don't have a mental health aspect, and there are no mental health aspects that don't have a physical health element to them. So an example of this would be an eating disorder, where children can be very low weight and have really significant physical health problems, or asthma, which we're becoming increasingly aware has a huge mental health component, and not just in terms of within the child, but also factors within the family, which can really impact on how unwell that child is with a particular illness. So what we think is that it no longer makes sense to treat physical and mental health problems separately. And this is what we hear repeatedly from families as well, because separating physical and mental health means that if children have a physical health problem but need mental health input, they have to be re-referred to a different service, they have to go to a different building, there's different trusts involved, different commissioning structures, and it becomes really tricky. And it's also about expertise and understanding around those conditions. So we're seeing an increasing number of children with physical health difficulties that have got a primary mental health cause, and our pathways of care to help support these children and families are really poorly developed, and there's very poor provision in the whole country for children that fall into this group. So we feel that the Cambridge Children's Hospital is a really innovative, exciting new way. It's a whole new way of looking at healthcare, and we've been working with talking to commissioners and talking to clinicians from physical and mental health trusts, talking to families to try to find a way to treat these conditions together, so that every child who comes into the health services has a really holistic approach to care, where we think about their mind, their body, their family, crucially their family and their environment. So working really closely with education and social care as well. So it's really exciting, and as Rob has said, this is a really new approach, and we think that this is the first time this has been done in the world. So it's really exciting.
Okay, thank you, Nancy. So there's more blurb on the slides as to how we're going about having to work this up. We've had fantastic support from a design team who have brought experience from Scandinavia to help us design mental health spaces adjacent to physical health spaces, and of course address all of the necessary safety and quality issues. So next slide, please. This you're not supposed to read, but it essentially tells you how integrated we already are with physical health services right across the region, and we are having to provide these specialist services in a really substandard environment. And it is simply no longer feasible to manage some of these complicated children on wards, competing with adult services in theatres, in imaging, and expecting the population across the increasing population of children across the region to continue queuing for London and outside of the region for this type of care. So it is a strong offer to the region, but of course our local population also benefits and currently actually struggles to get in, because very often we have children from around the region in our beds. Next slide, please. So just to leave you with this, the thought about the research, that the fundamental change that we are proposing in our research aspiration is to move towards early diagnosis and early intervention. So to change the paradigm of reactive healthcare, if you like, once the condition has arrived, once it's established, then how do we help deal with the symptoms, to a more proactive approach, so that many of the conditions, both in physical and mental health, originate in childhood. What is it that sets children up for poor health in adulthood? And there is nowhere else, and I think we have a fantastic opportunity in Cambridge to really focus on that preventative strategy, not only through genomics, but also some of the power of medical technology that we've got access to in Cambridge. So I think We, of course, think this is a super compelling argument in putting all these three strategies together, but we are still busy making our case on the funding front. So on that happy note, I'm going to hand over to Alex, who I think is going to give you an update on the design and the various steps that are coming our way.
Thank you, Rob. Thank you, Nancy. Hi, my name's Alex White. I'm the Cambridge Children's Project Director. I'm just going to give everyone an update on the progress that's taken place and what our next steps are over the coming months. So over the last 18 months, there's been a great deal of progress on the project, and you may well have seen some of that in the local press as well. Key to that has been finalising the scope of the project. When the strategic outline case was submitted, there was still a degree of uncertainty around the scope. That was confirmed towards the middle of last year and is listed out here on this slide. It's obviously a really important part of the project, and it was a really interesting piece of work to ensure we got the right balance of clinical viability, as well as ensuring that we were conscious of the limited public purse at the moment. So we feel that this, which is effectively phase one of a two-phase scheme, is a really viable and worthwhile scheme which addresses and enables the vision that Rob and Nancy have just described. I won't go through it in detail there, but just to say that of those 124 inpatient beds, around about 36, in fact, are mental health beds, and that's where the integration is at its focal point, if you like, for the scheme. And you can see also embedded within there is research space as well. So that was a key piece of work that then enabled the design to move on fairly rapidly, and we've had a very successful first stage of the design. The design process is divided into what's referred to as RIVA work stages. That's the Royal Institution of British Architects work stages, and there are 8 or 9 work stages. 9 is basically operational. So we've just completed and signed off RIVA work stage 2. We've also, as I'm sure you'll be aware, received full planning permission for the scheme. So we're in very, very good position with regard to the design generally. And you can see there a cross-section through the building that you may think that's an artist's impression. It's actually a lot more than that. It's using the cutting-edge architectural technology now. So that's taken from the actual design itself. So you can see that design on that slide actually represents some of the co-production that has been so fundamental in the design process. And all the way through the design, co-production has been a key underpinning principle. And there'll be more of that later on in this presentation. We also, as you'll be aware, have to write 3 business cases. The strategic outline case was approved earlier in 2020, and we are now very nearly finished with our outline business case, the second of the 3 business cases, and arguably the most important. We'll be submitting that in the autumn. But I think we've really done the hard work in terms of number crunching and the economic analysis on that business case, and it's looking in very good shape. We have a large proportion of philanthropic funding as part of this from a capital perspective. And again, that's been hugely successful, particularly over recent months. And we've secured the cornerstone gift of the philanthropy, which is really, really good news. It unlocks most of the rest of the philanthropy through underwriting by the university primarily, and also letters of commitment from Addenbrooke's Charitable Trust. So that a critical success factor in our project, and something obviously the Treasury has got its eye on when it will come to approve our business case. Digital is an increasingly important part of what we're going to be doing here and enabling the regional networking that Rob was just referring to. And so we're working very hard to get our digital strategy set out, and that is really coming into focus now. And then if I could have the next slide, please. We'll be refining all of that as we go into the next stages. Next slide. Thank you. So as I said, the next steps are to get the business case submitted in autumn. And we will then move, it's probably in parallel, to maintain progress and programme on the project, move into the next stage of the design and start preparing for the final business case of the three. And also then refining all the work we've done in the outline business case. So the outline business case sort of sets out, if you like, the theory, and then the final business case comes in and proves that theory. And the best example of that is the procurement we'll go through. So with the design, we will also have in the outline business case cost estimates by our cost consultants of the building, but then we'll go through a procurement phase to bring on board a building contractor, and that will be then when we prove all of those things. We prove that the design works, we prove that the costs were right. So that's when it becomes really quite real in the next stage, and we will be advertising once we get the green light from on high. We will be advertising and running a procurement exercise for the building contractor to do the works. We aim to start on site in early 2024. We regard that as a really important aspect of the project for a number of reasons. We need to vacate Ida Darwin by 2028. We're also fighting unusually high inflation at the moment, so maintaining programme is critically important, sorry. Any slippage to that can have impacts on our value for money as well. And we also want to maintain the excellent momentum that we've achieved on the fundraising as well. And of course, we continue with the good work that's being done on engagement generally, and in particular with regard to the co-production. So that's really where we are and what we've got ahead of us. I think I'm handing over now.
Over to Adrian, who's going to give you a whistle-stop tour of some highlights of the engagement.
Thanks, Rob.
I'm afraid also it's got to be whistle-stop to give time for the questions.
If I make it as quick as possible, then we'll skip the videos as well, given the technical problems, and perhaps they could be circulated with the minutes, perhaps, for people to take a look at. So, yeah, very briefly then, co-production engagement has been absolutely central to this project from the very beginning. And one of the main routes, one of the range of channels we've used is setting up something called the Cambridge Children's Network, which is a group of children, young people and families who are being brought to the heart of the project to share their views and insights. It's now got more than 500 members, and it's a really useful tool for us as a project. There's a little image here of Marley here with his dream hospital bedroom. Next slide, please. Yeah, very quickly, a few other headlines around the patient and care engagement. We've run almost 20 workshops looking at things like the hospital designs, the school space in the building, the digital strategy and art strategy. We've hosted a number of one-to-one sessions with whole families, kind of understanding that when a child's unwell, it doesn't just impact that individual, it impacts everyone around them, their siblings, their parents, their carers. So I'm trying to understand their collective experience as a family. We've recruited 5 young people into our press pack, which it's kind of a group of young people helping us to develop our multimedia content, telling their stories, writing case studies, and really kind of mucking in as a extended member of the communications team, really. We've gained a broad range of insights from the surveys that we've run on things like ward design and care pathways. We've run an all-day conference and webinar about the importance of food in hospitals and what the food strategy should be looking like. And we've started to get back out there, with face-to-face community events to raise awareness of the hospital, things like the recent Cambridgeshire County Day and the Festival of Suffolk. Next slide, please. So just briefly a bit about the design workshops. That's been a really important part of how we've involved children and young people. So we actually had a group of young people on the panel that interviewed the design team and appointed the successful design team, and understand gave them a very good grilling in the process. And they've been involved ever since, basically. So we had a number of design workshops last year and earlier this year. Had an illustrator capturing some of the key feedback and ideas that children and young people and families had, what they wanted from the hospital, how they thought it should look and feel. I can quickly show you a couple of those now on the next few slides. So yeah, you can see that these are some of the key things that came out from the workshops: the importance of colour, how the hospital should feel, and the senses that you should experience. And there was a conversation here about, do you think, a group of young people were saying, do you think the hospital should feel like home? And people were kind of like, well, sort of, but maybe not quite home, but homely would be nice. Next slide, please. And this is some more feedback that was gathered from the workshops, which pulled out, probably can't read the text there, but it pulled out things like the importance of connection to nature, lots of open spaces to play and breathe and rest, natural light, natural materials, which is all really important stuff that we've built into the design. Next slide, please. This is the cut-through image that Alex has already shown you, I think, previously in the presentation, but I just wanted to highlight a few areas where you can see that the patient and carer feedback and co-production has been built into that. So if you go on to the next slide, play was a really important thing that came out of the feedback and the workshops. So there's a quote here saying play is second only to staff. And you can see in the central area of the design here, nice wide open spaces with play equipment in there, and that kind of connection to nature by having it open up to the sky. Next slide, please. And this is another cut through from a slightly different angle. And if you go to the next slide again, you can see this connection with nature here. So there's a quote here saying that everyone is nervous when you go into hospital, and nature would be good as it is calming and peaceful. And you can see in the design here, these couple of spaces, you've got that greenery, not only externally outside the hospital and the landscaping, but also greenery built within the internal spaces in the hospital. Next slide, please. I've already mentioned the importance of colour. Hopefully you can see that from the facades, the main entrance there, you can see that we've got really bright colours built within the design there. Hopefully age appropriate to children and young people. Next slide. This was a really important piece of feedback. So people saying that they wanted a place in hospital just to be a family. And you can see in the design here on the left-hand side, you can see how all the wards will have space within, space to accommodate parents and carers as well as the young person. And sort of over to the right here, these kind of communal spaces for families to come together.
I'm afraid we are at time. I'm really sorry to interrupt you, but there won't be any time for councillor questions if we're not careful. Is there anything you'd like to say in closing?
I think just really quickly then, if I just skip to the last but third slides maybe, I just wanted to briefly say about our co-production champions, because it's a really important part of the project. So we've now got 12 parents and carers who are really plugged into the nuts and bolts of the project with us. They work with us at all levels, the project work streams, and also the most senior strategic parts of the project. And these are parents and carers that all have lived experience of using or caring for a child or young person who's used mental health services or been in hospital, and been really kind of fundamental to helping us give that parent and carer voice as we develop the integrated model of care. So looking at how we bring together mental and physical health, as well as various other work streams. And we've got plans in place to look at replicating something similar with children and young people. So perhaps looking to set up some sort of youth advisory panel, looking at best practice elsewhere at other children's hospitals.
Thank you. I'm sorry to hurry up at the end, but it's obviously of huge interest to us, and we thank you for the presentation, but also I'm sure councillors will want to make comments and questions. I'll take Councillor Goodliff first, if I may.
Thank you, and you'll be pleased to know you've answered some of my questions already. Firstly, I'm delighted to see the integration of both mental health and physical health. I think for too long we've separated both issues, and particularly with neurodiversity as well. We very much separate things and don't deal very well with comorbidity. So that's brilliant to see. In terms of my first question, which you may have already answered, I was asking or going to ask about whether or not these are additional beds. And I think you mentioned it was a mere 4 to 5 additional inpatient beds, which terrifies me. I think if we build such a brilliant hospital, and as you rightly say, it would be a regional facility, how quickly are we going to find that we need more beds? And in terms of capacity, we kind of have an issue almost from day one, I think would be my worry. If I give you all the questions, sorry. Then looking at single rooms, as a parent who's had a child in hospital, this is brilliant. It makes such a difference. It will make such a difference. I'd just to be aware that socialization, not only within family, but between children would be really key as well, and to make sure that that's there. And then also talking about design, I love all the ideas that you have and the input that you've had from various others. One thing I would be aware of, and it would be worth seeing if you could get some young people with sensory processing issues to really be involved in that. I've been in some lovely looking buildings with children with sensory processing issues and they can't stand them. So it'd be really key to kind of have that involved within it. And then my only other question is the key to success of all of this is discharge and how to have follow-up care and making sure that that works. And can you give a little bit more information on how you see that working, particularly as it will be over a very wide region and obviously working with an awful lot of other partners? Thank you.
Thank you. Can you make a note of the questions and answer them in a bunch? I'm sorry. Councillor Taylor next, please. Still unmute yourself, please. We're not hearing you. Can you unmute yourself?
Yeah, good.
Yep.
Okay, thank you for inviting me, Chair. Appreciate that. So yeah, mine's and again, absolutely look forward to this being started in 2024. I think it's something really, really to look forward to. But again, I'm going to touch on the beds. Is that right? That how many beds have we got for mental health? Is it? I've read in
36.
36. Yeah, so that's right. How do we know? Is it just that we're taking the same amount from what is existing in Fulbourn? How do we know this calculation is going to be enough? Because we have a rise in children's mental health at present. Is there any flexibility in this if we need to take more children? Also, is there a therapy department there? Is that something that's needed? Is it that sort of things that will need to be addressed? And also staff issues. So at present, there NHS shortages of staffs. How are we going to address that? And I'm presuming existing children's wards, like the ones at Hitchinbrook, will be staying. I'm presuming for the admission from A&E. So that's my questions. Thank you.
Thanks. I've got 4 other councillors. It's only advice, but can I say a minute each would help so that we don't eat too much in time of the Northern ICP who are waiting, and thank you to them for your patience. Councillor Murphy first.
Thank you very much. I really echo a lot of what's been said already, and I'm absolutely thrilled about so many things I've heard, including the integration of mental and physical health. Fantastic. I'm really interested in research because research is a critical aspect of developing treatments and new pathways and so on. And it was referred to, but only marginally. So I would welcome to understand 2 things. One is the balance between the kind of university clinical academic research and NHS research from the NIHR, etc. And the other is, to what extent are you going to encourage participation in trials to be normal, make it like a research hospital as modelled in the States? Thank you.
Next, Councillor Daunton, please.
So thank you very much for the presentation, and two declarations from me first. I'm the County Councillor for the Fulbourn Division, and I'm also County appointed Governor on CPFT. So my questions are concerning really Fulbourn and the replacement of the facilities at Fulbourn. I'm very glad to hear that. And I'd really like to know, it goes back to Councillor Taylor's question, how far on you are with workforce strategy, workforce modelling, because clearly one would assume that recruitment would be easier at the new facility. So that's one question. And the second question really is very specifically for eating disorders, which is really in crisis at the moment, and how you see the new facilities really helping to overcome that particular crisis.
Thank you. I'm going to take Councillor Hay next, but just to give Councillor Wood notice, you'll be the next after if you're ready to unmute. Councillor Hay, please.
Thank you. I wanted to ask about, within the report, it mentions the whole community, a hospital without walls, be a hub for the East of England, leveraging telehealth technology to go far beyond its walls. I wondered if you could expand on that a bit more so we fully understood what was involved in that. I also wanted to ask about, will the new children's hospital mean that the children's wards in Addenbrooke's, Peterborough and Hinchinbrook closed? Or will it be working alongside those? And how does the number of beds compare to the capacity we currently have in the aforementioned hospitals?
They're all great questions. Thank you for just keeping note of them. I'm sure you'll do your absolute best. Councillor Wood.
So just quickly, we've already mentioned the size. Will it be big enough? I better say I was on the planning committee and on reserve on the Joint Development Control Committee with South Cambs. So I'm very pleased to see this coming to fruit, well, being developed. But you've mentioned phase 1, you haven't really mentioned phase 2. My worries are really the overall size of the whole Addenbrooke site, CU8 site, and access. So access for parents and patients and visitors. If you could say something on that, thank you.
Thank you. Councillor Slatter next, please.
Thank you, Chair. I'm the County Councillor for Trumpington, and I look forward to seeing this from my window. It's a very exciting read. I got really excited. I wish I could have pressed the donate button and put £1 million in. But as you can tell from the tenor of the other contributions, I'm going to chime in, and probably my answer will go in with other people's. I've had interesting lunches with Dr. Christine Ann Rutter, who has tried to explain to me why it could be so small. I am badly surprised, really, that it's the first in the world. Now, do you really see this as staying as a regional hospital, or is it going to be a template for other hospitals, possibly in other bits of the region, that will be a bit closer to other people's homes? Because what you learn here surely can be replicated altogether somewhere else. What we do not want to see is bolt-on extensions. We end up with annexes. You'll be wanting to lease Douglas House again because you've run out of space. I would like to hope, maybe that's what you're going to say with phase 2, that actually what you learn here can be replicated elsewhere, cloned even, without it just spreading. Thank you. But I really think it's a lovely idea, and I'm so looking forward to seeing it growing and helping as a local member. We have to stay with the grumpy stuff at this committee, don't we?
And we won't start a debate about cloning, but thank you for using the word. I've got Councillor Corney next, please.
Thank you, Chair. And yeah, thank you for bringing this forward and sort of explaining what you're doing. I think this is great, and I suppose it's a bit more in depth in the funding, I guess. If I'm reading it right, I think we've got 220 million secured at the moment. I guess it's, do we know how much more, you've got to aim for? We've got all look down the back of our sofas and so on. But and then the next thing I'd like to know as well is, obviously, work should hopefully start on the build in 24. Do we have an anticipated sort of length of build? I know it's not. It does explain a little bit in there about the variables there and how long it, but just an idea would be great. Thank you.
I didn't know that you and Councillor Slatter both featured on the Sunday Times rich list. Councillor Garvey.
Yes, it doesn't mention anywhere about consultation rooms, but I presume there will be, but I presume they're in the design somewhere.
Okay, thank you very much. And Councillor Goodliffe, we wanted to just come back on one more word.
Thank you. The thing I missed out earlier, the paper mentions 42 day case beds, but Alex's slide mentions 28. Can you clarify which number is correct, please?
And mine in less than a minute. One is I really like the stuff you're doing on young people's engagement. I know it was sped up at the end, but it's in the report and we saw the slides. And I think it's a superb piece of best practice. I just congratulate you on that. My question, in terms of the philanthropy versus the public purse, is that just on the building costs or also the running costs? And what are the proportions? What's the ratio between private funding and public government funding that you expect, both for the building and for the running costs, so we can understand that? And Rob, in your presentation, you talked about actually quite a low number of beds and talked about support around the region. And yet we've also heard that there may be 160 beds in total, which sounds to me quite large. Did I just mishear you in your presentation, or is there some element that I haven't understood? If you could just clarify that, that would be great. We know you can only do your best, but we invite you to try and respond to all the questions and comments made.
Can I just ask how long we've got to answer the questions?
I think you have to try and answer all of them to the best of your ability. Otherwise, there's no point in us asking them.
Okay.
To the Northern ICP friends, I hope you may be able to stay a little bit longer this afternoon so we don't not do justice to that item. Rob.
Okay, so I will keep going until I have to hand over to my colleagues for help and clarification. So there was quite a lot of questions around scope and beds. So if we deal with that first. So we currently have about 67 inpatient beds, and we plan to go up to the mid-70s on inpatient beds. So an additional 4 inpatient beds, but there are about 7 or up to 10, depending on the flexible space, additional day case beds where a lot of the activity will go through. The reason for the 42 rather than the 28 is that the cancer day unit is attached to the cancer and oncology ward rather than being a medical or surgical day unit. So it depends on where you make the cut. And I think Alex has put the 28 medical and surgical beds separately. So just with, and the number of beds, we have spent a huge amount of time modeling the activity, as you might imagine. And there are a number of factors that are in that. There's the demographics of the region, the growth of various different age groups. But what we haven't included, and I think this addresses some of the questions, is any closure of any beds anywhere else. And that includes Hinchinbrook or Peterborough. So what we really are trying to address here is the regional specialist activity. So the type of activity that can't go to Hinchinbrook or Great Yarmouth or Ipswich, the type of children that need surgery, airways, intensive care, oncology treatment here. And the reason that we've only increased the inpatient bed capacity by a small amount is that the productivity that we are able to get out of the co-located day cases with theatre, the co-located wards with staff is almost 50% more activity than we are able to do now, because we are scattered in 17 or 18 different places around the adult environment. The amount of activity we will be able to put through MRI scanners, because we've got them on the same floor as theatres next to an anesthetic room, is twice what we can do now. So there is an enormous amount of efficiency going through this relatively small building. And it does seem shocking, and we have to tell this story many times. How can you only have additional beds? But we really do feel the combination of better productivity and efficiency within the building, the adjacencies being designed rather than historical, as well as strengthening the networks around the region. And I think there were some questions about networks around the region. So I hope that it addresses some of the bed capacity issue. This is modeled to 2034-35. At which point, and we haven't talked about phase 2 because we'd like to start with phase 1. There is a block of additional ward space, additional theatre space, outpatients, and I know consultation rooms are also a hot topic. We haven't been able to fit outpatients as a block into this phase 1 build. It will come in phase 2. So the released spaces for inpatient wards on the Addenbrooke site will be released to other purposes. However, our outpatient department will stay largely where it is on the Addenbrooke site until phase 2. Fulbourn, of course, will be relocated lock, stock and barrel across to us. On the numbers of inpatient beds for the mental health side, the modelling has been just as rigorous. And we believe through the initiative now, the new care models, which are looking to provide stronger crisis and community services, that we can reduce that element of beds, whilst also repatriating patients from out of region and the private sector. So we think that roughly 36 beds, which is what we have now, will accommodate what we need up till 2034, 35. We also have some flexibility of about 10 or 12 beds that allows us to flex mental health into physical health and physical health into mental health. So not only are we able to have shared staff in these areas, but we are able to flex to a degree mental and physical health patients to help that sort of ebb and flow of physical and mental health. So just running through some of these other questions. So single rooms, the new building standards are all expecting single rooms. We have made and insisted with our designers that there has to be the option to open up walls between single rooms to allow children, particularly who are staying a long period of time, to have company and access to other children. Your sensory processing issue, this point is very well made. We aren't yet into the sort of detail where interior design and the sort of detail of the design is ready, but we absolutely cited on needing to include families and children in understanding that the sort of VR internal spaces haven't been designed yet, so we're not quite there. In terms of the networks and managing children locally, we already have, and one of the slides showed, we already have pretty strong existing networks on the physical health side. The provider collaborative on the mental health side is evolving and developing as to how to support children closer to home. We have, and we are relatively behind the curve with our digital sort of detail, because we've had a lot of other stuff going on. But we are just about to kick off a big piece of work with British Telecom and their R&D support service about how we strengthen digitally the infrastructure for sharing staff, sharing bed capacity, sharing available resource around the region. So there are 16 units who largely function in isolation without easy and free access to expertise. And we think that with a better platform, we will be able to manage the front end and the back end of many of these pathways locally without having the whole pathway have to come to Cambridge. I wonder whether, just to break up my monotony, Alex, you want to take some questions on funding and
or should I do eating disorders
question,
yeah, and
okay.
Also about the integration of children? If that's
Perfect.
Okay.
Alex, you're next.
So in terms of the eating disorders, yes, there's been an enormous rise in referrals for children with eating disorders in the last couple of years. There's a lot of, it's really interesting because there's a lot of discussions nationally about how we manage children with eating disorders and what the best pathway is. And I think that's within, I think the integrated model really lends itself to the discussions that are being had, which is looking at having short admissions for children with eating disorders, where you can address issues very sort of in a few weeks to make them physically stable and to input into supporting families to support their children and with a view to getting them home again, and also strengthening community offers so that children can be managed can be treated at home. There's also discussions around having a day patient model as well. So I think there's an awful lot of discussion around that at the moment, because you're absolutely right, there's been a huge increase in referrals, and I think that is still developing, and the national picture and the national recommendations are still developing regarding that. In terms of somebody asked about children being in separate rooms and needing to integrate, and I think that's a really important point. In the unit where I work, which is an under 13s child and family mental health inpatient unit, we have a model where the therapeutic environment is incredibly important, and we're trying to really replicate that in the children's hospital, with having a lot more spaces within the ward for families, for children to play, for siblings to be, for families to be. There's a lot more sort of meeting rooms to have private conversations. There's dining spaces in every ward so that families can sit and eat together. Food is an incredibly important part of this, and there's a lot of work that we've been doing to try and make the food offer work for children and families, and there'll be more play spaces as well. So we're absolutely thinking about that. I think you're right. I think it's really important. The school offer is really important with that as well. So there's a lot more classroom spaces, and the concept is that we're thinking about the family and the function. So helping children who might be in hospital for, well, we hope not long periods of time, but if they are, that we really work towards helping them maintain their function. So.
It's coming up to 3:30, so I do need to close it. No, Alex, do you want to come in? But just a couple of minutes, please.
Yes, of course. Thank you. Well, I'll answer the numbers question quickly. So you're quite right. Previous cost estimate was 220 million. That was some time ago, and since then we've clarified and added to quite significantly the scope, as I've explained earlier. So that's obviously put an upward pressure on the numbers, as have inflation. As I mentioned, it has, as everyone knows, it's very, very high at the moment. And other initiatives that we need to quite rightly incorporate since we last costed the scheme, including net zero carbon and the digital agenda. So all those have added to the cost pressures. The combined effect means that we're now looking at around about £390 million for the scheme. And the way that's broken down, £100 million of that will be philanthropy. There's a £20 million land sale capital receipt that's already gone through from CPFT, so that's sitting waiting. And then it will be £265 million worth of public dividend capital, treasury capital, and a further £5 million or thereabouts from the local education authority. So I hope that answers the question. And then just coming back to the point about the sensory processing issues, we do have close links with Alderhay, and as you may be aware, they are just about to open a new mental health facility up there, and this is one of the issues they've explained to us as well, and we're going to go and visit them to understand how they're addressing sensory processing issues, and we're hoping to go up there in early August to have a look at that new facility.
Rob, just one final sentence, but let me invite you to give us the last word.
Thank you very much for taking the time and squeezing us in. We're very happy to respond to the other questions in writing, particularly around the research and the learning that this hospital will bring to the region, and we hope more nationally that we will study not only the clinical model and how that should be applied and how well or not that works, but also the hospital is very much looking to be a clinical research hospital. So we want to leverage all of that power. So really, on behalf of all of us, many thanks for taking the time to listen. We'll be back, I'm sure. We hope that we've given you a good oversight of what's going on. There is progress despite all of the other challenges. So thank you very much.
Can I say thank you very much for us to you and your team. You saw the interest in the project through the range and number of questions that were put. Thank you if you're able to do some written answers as well. We really appreciate that. And I think you can see we're excited by the project. You're excited by the project. You certainly communicated that. all of your team, but we're excited by it too. We wish you luck. I think having this discussion in public will help build your business case. I think you probably saw the advantage in that, in the way that you talk to us, but we're very pleased by that. We wish you success, and we look forward to seeing you next time to measure the progress that you will make. To the committee and our online friends, the recommendation is that we note the content of the report and the project's key milestones and next step. Everyone happy with that? Seeing notes all round, and I think notes online. I have to have online notes. I've got them. That's fine. It's agreed. So thank you very much. If we can swap with the two next guests joining the front panel, I'm going to take a 60-second comfort break, no longer. So if I couldn't call this to order again, thank you for your indulgence, allowing that short break. Last item, but a very important one in our entire agenda, is a session with our friends from the Northern Place Integrated Care Partnership. Can I welcome to the committee Michael Kaiser, Managing Director of the North Place. Michael is on the left, yes, and your colleague Robert Murphy, who's Programme Director, on the right. I want to say in introduction to this item, which by the way, your report is on pages 345 to 354 of the agenda pack. We appreciate that this is very early on in the life of the ICP, and we've deliberately invited you, knowing that we don't expect you to have all the answers to all the questions, but to have an early chance to interchange with you, given our integral role working with you, we thought was a really important aspect. We've had many discussions with the board in the partnership running up to the creation of the ICS, and we want to forge as close links with you and your colleagues, South Place as well, of course, but we're using this as the opener to really hear what your thinking is about how it's going to develop, rather than expect you to have completed answers. So it's in that spirit that we've invited you, and the Vice Chair, myself, have obviously been involved in intensive discussions around the ICS, but there will be a range of councillors around the room and joining us online that may not have all the background, so please do feel free to discuss what the ICP is as well. So having made that introduction, thank you again for your patience in us starting slightly late. I'll hand over to Michael.
Thank you. So as new as it is, and as in its infancy as it is, I'm on day 8, I think, in this job. So hence why Rob, who's got a lot more of the history, is going to be here and talk through a lot of it. And between us, we'll do the best we can to field the questions and answer as many of them as possible. It's really important to note that it's in its infancy, and we're trying to be as collaborative as possible. So we really welcome that approach. So I'll hand over to Rob to talk through everything, but I'll be here to answer the questions as well. Hi everyone. So yeah, I'm Rob Murphy. So I'm the Programme Director for North Place. I'm a pharmacist by background, but have been in NHS commissioning for about 10 years. It's nice to meet you all. So we've submitted a paper, obviously, to the committee, which I'll take as read rather than walking you all through that, and just pick out some of the key points that I think could be interesting for the committee to think about and comment on. So first of all, as you say, Chair, just a little bit about who North Place is, because I appreciate there's lots of jargon and different terminologies within the ICS. With the passing of the Health and Social Care Act recently that created ICSs, our ICS has decided that to focus on the populations that we have within Cambridge and Peterborough, having a North and South Place, which is aligned to the catchment areas of North West Anglia hospitals, which flow into the north of the patch, and Addenbrooke's that flows in the south of the patch, but also via a natural kind of cut-off between the district councils of Hunts District Council and Fenland District Council and Peterborough City Council form two north and south catchment areas of the patch. And that allows us to focus on the different demographics that we have in north and south of the patch, with different priorities around levels of deprivation and rurality across the patch, and allows us to create pathways and solutions for those populations more specifically. And so North Place is being stood up, as you say, as we are currently doing that. We first started the work as being North back in 2018 as a very loose alliance of all the statutory partners of health and care bodies in Cambridge and Peterborough and the north of the patch. And that has grown through doing some useful, hopefully, and productive work together, showing that we can make a difference to some of the patients and public. And then that has created some momentum around the purpose and the justification for having North Place as a more permanent part of the NHS and care infrastructure going forward. We are an alliance currently of all the partners in health and care. So we have voluntary organisations, we have the local authority, the district councils, 49 GP practices, 2 GP federations, a wide stakeholder group that form North Place. And the aim is to try and integrate and share purpose and priorities across those organisations to drive improvements and outcomes for that population. There's a load of other detail in the paper, but I just want to focus in on sort of 4 or 5 key points around what's driving some of the work we're doing. So one of them is about subsidiarity, which is how do you do more things more locally for local people instead of having a very large organisation rather distantly from all patients, which is how a 1 million population ICS could be construed, and trying to devolve decision making and engagement and input from patients and public to the most local level we can. So at North Place, you are obviously then having a look at that North demographic and North population. Within that, we have 13 primary care networks that we want to develop into what we call integrated neighbourhoods. The idea being that those GP practices can call on and work very closely with your Care Together Think Communities programs that are local authority district council programs, with our community services providers and the local teams they have, and the voluntary organisations that operate within that patch to devise local solutions for local populations at a community neighbourhood level, where we believe that you can get the most integration and the most benefit for patients that meets the needs of the local population. So that's kind of really one of the drivers for us. We want to make best use of the shared money and the shared resources we have across the North Place. So we are aware that we collectively have a very large amount of money that is spent on health and care across the North Place. I think that allowing the North partners to come together and work out where we duplicate each other, where we might create waste between each other, and try and eradicate that by working more closely together in an integrated way is something that is a responsibility that we should be taking on and trying to drive in the system, particularly given the financial environment that I'm sure you're aware of affects Cambridge and Peterborough for health and care. We're very keen to drive those outcomes, to stand up our place team. So how does Michael and myself, which is 2 of a very small team of people that are in the core North Place team, start to work with local authority colleagues, transformation teams across NHS partners, and form a team that can actually deliver on behalf of the NHS and care organisations and make sure we can drive the outcomes that we should be held accountable for. So we're in that process of working out how do we make create the team that can deliver for our patients and public. And we're in the process, as you say, Chair, of devising, well, how do you structure that? What does the governance need to look like? And how do we make sure that we've got patients and public built into the governance and the infrastructure of North Place? how do we make sure that the right partners feel part of the boards and the committees that we have in North Place? And we'd be very keen, I think, for health committee partners to be part of that discussion and be part of the membership of some of those boards and committees to hold us to account and to help and support us engage with patients and the public and the local system. The last thing, I suppose, is just around some of the kind of areas where the local authority might be able to support and help us. So that point around how do we share management staff and leadership and make sure that we've got cross-fertilization, I think, between our leaders across health and care, making sure that we are sharing priorities and aligning what we do. I think that there's always a need for us to communicate better with local patients and publics in our neighbourhoods. And I think the local authorities and district councils sometimes do that much better than health does sometimes. And I think it'd be really good to get a kind of a shared buy-in to how do we best talk to local populations, local neighbourhoods and local communities and learn from what they're telling us about health and care, about what their priorities are, and also communicate what we're doing so that they're clear on what the purpose of building a North Place is and what we are and what we aren't doing. And finally, how do we join up health and care? I think one of the long-term aspirations for the NHS and local authorities is to work more closely together, integrate services, and to join up what we do. And I think that's a big driving force for some of the work we want to do in the North Place. And it'd be good to get the committee's views on how do we prioritise and start to join up our services in a meaningful way. So as I say, I take the paper as read. There's loads of content in there, but I'm conscious of time, Chair, and I'm very happy for making time for questions at the end of our talk. So back to you.
Lots of content and also in the written report, which we're very grateful for having received in advance. Can I ask members to indicate? Online, any hands going up? And perhaps just to pre-announce, before I bring you back at the end, I might ask Will to make any comments after hearing the member contributions. So, Councillor Bowden is first.
Thank you very much indeed, Chair. First of all, I'd like to say that I wish all of those involved in the ICS project the best of luck in achieving the objectives that we all will want to see, the outcomes that we'd all like to see. And I have to say that because my next few comments aren't going to be very positive. And let me explain why. I think that I've been through 3 major reorganizations of health and social care. And each reorganization is significantly disruptive. And there's an enormous amount of political as well as financial capital involved and organizational capital in managing to change from one system through to another. And I completely agree that we needed to move forwards from the CCG system that we had. It had some positives, it had many positives, but it had many negatives as well. However, the Health and Social Care Act raised large expectations, but was actually really very unambitious in my view. And for that, I blame national politicians of all parties. But I really feel that until we get to the stage where we have funding allocated in an appropriate way between the different parts of the health and social care systems, until we get to that position, we will not have the major changes that we need in order to have a more efficient and effective health and care system. Within the NHS, there's a lot of good arguments to explain why there should be significant resource movement in percentage terms from the acute sector to primary care. Between the health service and social care, there was also very good cost-effective reason why there should be a greater proportion of that particular cake going to social care than to health than we have at the moment. ICS and the way in which it's being set up will help to some extent move those goalposts, but I believe that the effect will be relatively marginal compared with what could and should happen, especially if you had some degree of movement of the ownership of budgetary responsibility more than is shown here. So I have to say that I wish the new ICS system every success. More than happy to assist to the extent that I can, whether within Fenland or within Cambridge County Council, in ensuring that we have as much success as we can. I just warn against expecting too great a result from the system which we are forced to work within. And on this specific issue about the north area, or the splitting between the north and south, I'm not at all sure that I understand the logic of having Ely in the south and Huntingdon in the north. I have a great deal of respect, of course, for district council boundaries, but I'm not sure that necessarily they should have been the criteria which were used. It is what it is, and we'll have to live with it. I'm not at all sure that that was the right way of splitting it. Thank you, Chair.
Thank you. Councillor Daunton, please.
I'm just wondering where the non-professional person was involved in terms of the consultation for setting up the plan. Point 2.4, you say our place-based plan has been developed with our partners, providing an opportunity in this early phase of development. What about the members of the public, the patients, the users of the services? At what point were they consulted and how were they consulted?
Thank you very much. Next, I've got Councillor Goodliffe, please.
Thank you. Looking at the outcomes data you have here, obviously there's a clear need to make some change in the area. I think this is a historic thing. Can I ask what you're doing differently and how you're going to get buy-in from residents, from people there, in order to make those changes in health for people? Thank you.
Thank you. Councillor Slatter, please.
Yeah, it's a real challenge, isn't it? The merits of a specialist and having to travel to find the specialist, the merits of being able to have a particular service, because there's a lot of people with that problem in that area, and worrying about what happens to the only one person with that particular condition in a village. There's no easy answer to this. And I think that when you're also putting an administrative framework on top of human geography, you really have a problem, because there are some places with lots of really charitable people and a brilliant church and a good school and so on. You get all that buy-in from them, and another place which, for no fault of its own, hasn't got those things. So we're all on your side on this one, but we know it's a really difficult thing. And Councillor Bowden has put his finger on it. The readiness to give up control of budgets is a tricky one, isn't it? Because we know that it's really foolish to not to invest in something, even though your budget does not see the benefit. It's clearly not, it is sensible to invest in good housing, even if you don't save money because somebody doesn't get asthma or whatever. So we know that that's a problem, and we welcome the fact that maybe these budgets are being pooled. And I readily agree that there are going to be places with inequality of need, and some people who've got a minority of need just need to make sure they know where the good provision is, what it looks like, and try and get it for their residents if it's not actually on the doorstep, whatever that provision might be. So that's up to us to be well informed of what's available county-wide. But I'd rather have to leave it to the people with the experience on a larger political scale. But you're quite right, it is this readiness to give up the control of the budget, which might mean it gets spent somewhere else. But we hope, if we're all feeling we've got common aims and common interests, and we are prepared to invest in one another and spend the money well, because there isn't a lot of it. Sorry, that was just a thought for the day. Sorry, it's not a question, Mr. Chair, but you didn't expect one, did you? It's not that simple.
Anybody else before I bring myself in? No, well, first of all, thank you. Thank you for coming so early on in the tenure. We hope this will be a very useful discussion for you as well as for us. And you've heard where several colleagues' questions and concerns are, so very interesting dialogue that we'll have on the back of it. hostile just by echoing the budget point, because you'll have heard it then from every party group on the council, absolutely cross party. It's about whether this will mean changing the budget. All of the rhetoric was there before, all of it was meant in good faith, but in reality, as our Director of Public Health has often told us, there's a spectrum between what you spend on treatment at the one end in the acute sector and what you spend on prevention at the other, and it's where you come on that spectrum. And if this is to work in the way that I think all of us would hope, then the resources have to be reallocated on the spectrum more towards prevention, and not just you support prevention and social care and keeping people out of hospital, but that's our job and we pay for it, and you do the rest, but genuinely that you invest in that and invest the budget within it. So you've heard that question from three of us. So I think it's one that's obviously on our minds. Like Councillor Bowden, I apologise. I think the northern geography is a bit of an artificial construct, really, but I agree we are where we are. And when our administration took over, it was obvious that unpicking it wasn't going to be helpful or constructive or probably even successful. But the health needs in Peterborough are really different from the health needs in Fenland, aren't they? You couldn't almost get more different in many, many respects. And so convince us, I suppose, that you really have got the flexibility to deliver two different types of services between Peterborough and Fenland. Thirdly, on the partnership, and I think Councillor Stato said this, and nobody's wiser than anyone else around this table, but I felt, this isn't a criticism, but I felt you were still talking about you, the NHS, doing things and us supporting you. Yeah, I think you use those type of words rather than us being partners in the whole system. And I think that's hard for all of us. I think it's hard for the local authority as well. So I don't in any sense want to say that in a critical way, but you talked about your integrated neighbourhoods and our care together. Somehow we have to make those mean the same thing rather than be two separate things. And so when you're asking us how can we best communicate and use the right channels, it's like two bodies using channels to communicate. We should be one system and one set of partners communicating together using common methods, not just to communication, but to deliver at the local level. That is the aspiration, surely. And tell me if I've got that wrong, of course. But if it's also your aspiration, then we need to sort of really ramp up our thinking about that, I would argue. And just to say, I'm sure you're very aware of this, but all of the work we've done over the last year has been about bringing together the ICPs and the Health and Wellbeing Board and trying to make them as identical as possible. I'm sure you're aware there's a legal problem, which means we can't make them, actually merge them. But we're going as far as merging them as the law will allow. And that's pretty damn close in certainly the opinion of those who we meet in the ICS and ourselves. Do you share that aspiration? Is that being communicated down? How can we develop that together? It's quite a few questions. Sorry. I won't take longer than my due time. I think Councillor Daunton has asked an important point about people involvement in this. We've had a lot of discussions, but how does this pass the people test is a really good question, and I support her question to you. Thank you for saying what you say about members joining some of the boards and so on. What we want to do, though, is to avoid a sort of patchwork that sort of suggests we're involved, but it needs to be systemic and systematic, and there needs to be accountability. There needs to be reports back to the two upper tier local authorities, and we need to be able to sometimes agree and sometimes disagree, and have some checks on that. So what are your thoughts about that? I've done that. Two of the priorities we've put in our approach on the integrated care system are the real living wage, which you do refer to in your paper. Thank you very much for that. And we see that as being essential to both be socially just in the way that we deliver services together, but also, frankly, to be part of the proper response to recruitment crisis that we all face in relation to this. And it's great to see that in the paper. Thank you for putting it in. And we hope that will be a kernel of everything we do together. We also very firmly want to see more public services, and we've heard nationally assurances that this isn't a route to greater privatisation, more private sector commissioning. We're not going against that. Large amounts of what we do is through private sector commissioning, but we don't want this to be a further leap towards that. If anything, we want to bring some services back into direct provision, and it would be good to hear your comments about this. That I think that's my time. It's certainly the list of questions I've got in front of me. I don't see any other hands looking around, so I invite you to oh no, I was going to ask Will to comment just before I bring you in. Will.
Thank you, Chair. So I'd say three things. I think as officers of the local authority, we've been fully engaged in the development of the plans and the priorities of the North ICP. We've had really good engagement, and I would like to think that there's an understanding around mutual dependency, particularly in terms of delivering outcomes. Although I would say also that it's clearly very early doors for the North, and sort of linked to that, they're encouraged. I'm encouraged. There's strong alignment around words around the integration agenda, our Care Together programme, decentralisation, and particularly with the emphasis around prevention and early intervention. So I think certainly from our officers' perspective, there's good engagement and there's a lot of commonality, and it feels like we're moving ahead in a mutual way and in a way that is aligned. I suppose and this has been raised already, the allocation of funding and how that gets allocated, where the benefits fall, and how we collectively move away from the system that we have and experience day in, day out today into a more mature relationship, I think is going to be really important for this to be successful. And then the second point to that is the sooner we get through the planning process and the setting up process and teams in place and what have you, I think we're really keen to get on and agree the areas that we want to really prioritise in terms of delivery and focusing on. So that's what I would add.
Thank you very much for that. Can I hand back to Michael and to Robert?
There's quite a lot to go there, isn't there? So we'll try and work our way through it. I think I just want to acknowledge the first point. Actually, I'm not sure there was fully a question there, but I think there is a point about we've done this repeatedly, and what's different this time. It costs money, it costs time, it's disruptive. And we were asked this question earlier. We were at an event this morning with colleagues from local authorities, from healthcare sector, from social care, and from voluntary sector. And my answer was, well, when we've done this before, it's always been one organisation or another that's got to be accountable. And we're now here with a new thing called the ICP that can sit between all those organisations and be fairly neutral and support each other to work collaboratively and to hold each other to account as well to get some real delivery. So I think that's different to before, or it's early days and I'm still being quite romantic about it. But we'll find that one out, I guess. But I'd like to believe that's quite a different answer. There was a point on the place-based plan, and did that have our partners and particularly the public engaged in that? So I think, Rob, I wasn't around when that was written. I'm 8 days into the post, so I don't know if you've got a better answer than I will have for that.
So I mean, I think my point is that we're at very early days in terms of the development of North Place. The ICS more generally was very obviously had a large piece of engagement work with patients and the public about the development of the ICS. North Place is just going through a similar process, and I think that we're just designing how do we make sure that patients and the public are part of the way in which North works. We've been going through a program of trying to write some of the terms of reference for boards and committees, and one of the things we've tried to make sure we fit into that is the role of Health Watch, the role of patients and the public on those key boards, to make sure that we are held to account and we are getting engagement and feedback. So I think it's best endeavors to make that work. I think we welcome constructive challenge about whether we think that's permeating into your neighborhoods and communities and localities, about whether you feel that's actually working or not. And I think that we'll bring back in the future kind of more detail about how our boards and governance looks, that kind of assures you about what the engagement does look like. But I think it's still a work in progress.
Do you want to talk about the PCMs? There was a comment.
Yeah. Yeah, so I think there's a very sensible point made around even within North, you still have very different patient populations around Fenland and around Huntingdonshire and around Peterborough. The way in which we've kind of tried to address those is that we have 13 primary care networks that is the next level of subsidiarity down from North, and so they each have about 40 to 50,000 patient population and are broken up into South Fenland and Fenland and Wisbech and the different primary care networks. They very specifically will try and create solutions for their local populations. And our view is not to tell them what they should be doing in micromanaging them, but trying to devolve as much decision making and funding down to them as we can, so they can make the right decisions and right choices for their local populations. So trying to take as much of the decision making as we can down to local communities, and accepting that means we're going to have 13 slightly different localities and communities across North Place. We don't think there is one size that will fit the whole of the North geography, that it will be different solutions in different areas, and we need to embrace that and accept that that might mean that things are different in certain areas, but that's probably the best way of getting local populations engaged and finding the right solutions for them.
There was a point about the language used in the report. Forgive me, I can't remember who raised that point, but I think it's absolutely valid that this isn't an NHS concept. This is a collaborative between health and social care, between local authority. And when we say between health, it's between primary care, secondary care, community providers, it's between voluntary sector, local authorities and social care. It's important that we work collaboratively, and I think Rob in his introduction earlier mentioned that we could achieve more than the sum of our parts if we work collaboratively, and I don't think we've ever quite got there before. We've tried collaboration in healthcare, and often that's talked about primary and secondary care working together. And I think you guys in local authority have got a wealth of experience around how you work collaboratively across different sectors. And I think we need to show some humility and learn from that. This absolutely isn't, and nor should the language read as, please come and attend our party. It's not that at all. It has to be collaborative. And I think that touches on Will's point about maturity. And there was another point about being able to disagree. That shows a level of maturity as a system if we can get there. I don't know if we're there or not yet, but we need to get there fast, because if we can work collaboratively, we can achieve some real good outcomes for our patients. I heard somebody this morning talk about this is about a population. Actually, I would say this is about every single individual patient and person. That is, we might say patients in healthcare, we might say service users. It's about every person and how we can cater best for them and achieve the best we can for them. I was also quite, I don't know if this is an answer, but I was quite excited about the comment around prevention earlier here today. It was a comment that came from Huntingdonshire, actually. Huntingdonshire District Council colleagues earlier particularly talked about prevention. I thought that was going to be more of a challenge for me in my role to work with local authorities to look at prevention, and how wrong I have been proven today, because that's quite an exciting challenge to try and tackle. We might not see the benefits of that tomorrow. That might be a slower burn, but that's something that I think we can work together on. And just to come in, a number of councillors raised the resource shifts and how we're going to try and crack that.
I think I'd accept we haven't quite cracked that yet, but that certainly this morning we had as Michael referred to, we had a meeting of partners, including the chair of MWAFT and the chair of CPFT as two of our large foundation trust providers, and they very much were supporting the idea of we need to be getting relatively proportionally less money, and more money needs to be going into voluntary organisations, primary care, preventative services, to try and bend the curve of the otherwise constant firefighting that we do in our system in terms of meeting today's needs versus planning how we're going to prevent those high-risk patients manifesting in future years. And I think that principle was fairly strongly supported this morning. The mechanisms and the detail of how we're going to do it, I think, is still going to be a work in progress and is one of the big challenges for our healthcare system. I'd also put that shifting from acute and hospital services into preventative services goes alongside shifting money from areas of affluent areas of our patch to areas of deprivation, and how actually we're going to focus and target funding, resources and allocation to areas where we have the highest need, dictated by the wide determinants of health and things like housing and deprivation. And that goes alongside the preventive aspect, but it's a slightly different slant on where we might target and fund different resources. So both of those, I think, are mission critical to North Place, but they are works in progress in terms of how we're going to address it. And then the final point I was going to make was we raised about the private sector provision and in terms of what our approach is to that. I don't think that we have an explicit policy around whether we do or don't use private sector organisations. The natural drivers, though, for us in the NHS, particularly from my background, are that paying private providers to provide services takes money out of local NHS providers and actually is not economically beneficial to us. It's much more beneficial to bring things in-house where we can and provide them in-house. We get better integration, we get better joined up services, we get less duplication of services, and actually we get more sustainability and resilience if we can do things in-house. So the drivers in NHS land are very much around more NHS and public provision rather than less, and that we only really see private provision where we have gaps that we can't plug in our service provision because either we can't recruit staff, it's a specialist area we haven't got services for, but it certainly isn't the norm in terms of the way that NHS operates. We try and work within our NHS and care partners in the first instance, I think. I think I'll stop there, Chair.
On that last point, it is only one of several points you've heard, but we made the same point to Jan Thomas when she appeared before this committee. Good to hear it, good to see it written down. Great what you said, but much better if it's also written down and explicitly communicated with your other messages. I do see one come back. Councillor Sutton.
While you've been talking, I've been using the rather splendid My Cambridgeshire maps. I think we all tend to do our homework on those because then we can find out about other bits of the county we haven't been to yet. Have you come across those? There's a massive, massive amount of information there, particularly about local government services. Please add NHS. You've got the bare bones there if you look, and you'll find there's GP surgeries, addresses, and so on and so forth. Alongside that, you can find out who the councillor is if you want to. But also, I would like to know, what are these 13 neighbourhoods in North Place? I mean, I know which one mine is, I know the one next door, but and that would be really quite helpful when we're trying to be helpful. And you might also find it quite useful. The more, I believe it's the best place to find lots of things together. If somebody's found something better, I don't know, but I know this is our home map and it's brilliant. It really is. I use it for people just coming in from Hong Kong and show them this is how we're organized, and you can click on it, and it also gets through language barriers because it's visual. But please do add your information if there's ways of doing it. Probably the officers are now going to hit me, but there must be ways of your getting into our system, I'm sure. Thank you. Sorry, thank you, Mr. Chairman.
I don't think officers hitting members is part of the Constitution last time I checked. Knowing our officers, I don't think it's very likely, I have to say. We'll just take that as a good piece of advice. Don't feel you need to respond, but I'm sure it was a good piece of advice. So, great, thank you. Come back again soon. We know that there's a lot of fruitful contact between yourselves and our own officers. We encourage that to continue. I think we're all agreed on the rhetoric, right, and the philosophy. it's actually whether we deliver it is a big issue. And you know, my closing plea to you is build bottom up, not top down. Worry less about getting those boards ready first, and to put your emphasis on bottom up first, and then create the things from that. And if you can do that, it will pay you back, not money, but it will pay you back in every way in years to come, and it will make subsidiarity a reality. And it's difficult because we're all systems people and we're used to dealing with structures and stuff, right? But try and reverse it. And that's the challenge for all of us, not just for you. It's a challenge for us as well. And see us as partners, committed to integrated services, see us as those partners, because that has our strong political support from ourselves as an authority. Can I put the recommendation to the meeting, which is that we note and comment, as we have done, on the contents of the report. Everyone happy with that? Fairly anodyne recommendation, looking online as well. To Michael and Robert, thank you very, very much. And thank you for extending the time so that we could do justice to this item. We're extremely grateful to you. And can I just say to all the officers and all the members, I think that once again, we've had a very rich meeting today, which has, I think, been really fascinating and fruitful and learning for all of us. And I hope we've taken some good decisions along the way. So thank you very, very much to everyone for taking part. And I announce that the next meeting is on the 5th of October 2022.